Syncope. 1. What is the first step in evaluating loss of consciousness from syncope? The first step is to ensure that the person actually lost consciousness. Simply falling or being less responsive doesn't necessarily mean there was syncope. 2. What indicates true syncope? In true syncope, the person cannot hear people speaking to them. Also, urinary or bowel incontinence is too nonspecific to be helpful in diagnosing syncope. 3. How can we differentiate between sudden or gradual loss of consciousness? Sudden loss suggests a cardiac or neurological cause, such as arrhythmia or seizures. Gradual loss, likely caused by toxins or metabolic problems like hypoglycemia, hypoxia, or drug intoxication. Vasovagal. Syncope can happen either suddenly or gradually. What does the sudden or gradual regaining of consciousness tell us? Sudden regaining points to a cardiac cause, e.g., valve disease, ischemia, arrhythmia. Gradual regaining, often seen in generalized seizures, except for absent seizures. After a seizure, there's typically confusion that can last up to 24 hours post-ictal state. 5. What should be noted about the regaining of consciousness in seizures? People who have seizures do not immediately regain full awareness. They're confused for a while afterward. 6. What should be checked if a person experiences sudden loss and sudden regaining of consciousness? Cardiac examination. If both the loss and regaining of consciousness were sudden, check the heart for issues. Normal exam. The cause could be arrhythmia, and tests like EKG, telemetry monitoring, and troponin levels are needed. Abnormal exam. The cause might be related to heart valve issues or other conditions like aortic stenosis, AS, hypertrophic obstructive cardiomyopathy, HOCM, or mitral stenosis, MS, which require an echocardiogram. 7. How should syncope be managed? Management depends on the patient's history and physical examination. Common tests: head CT, EKG, cardiac enzymes, and echocardiogram. Hospitalized patients. Cardiac telemetry is used to monitor for arrhythmias. Discharged patients. A 24-hour Holter monitor is placed to check for arrhythmias. 8. What is the main cause of mortality in syncope cases? About 90% of mortality from syncope is due to cardiac causes. Coronary artery disease, CAD. 1. What is coronary artery disease, CAD? CAD refers to a condition where the coronary arteries become narrowed, reducing blood flow and oxygen delivery to the heart muscle. It is also known as atherosclerotic heart disease or ischemic heart disease. 2. What are some non-cardiac causes of chest pain? When chest pain is not due to ischemic heart disease, common causes are gastrointestinal, GI disorders such as GERD, gastroesophageal reflux disease, ulcer disease, cholelithiasis, gallstones, duodenitis, gastritis. 3. How does the risk of CAD change with age in women? For a 48-year-old woman with no risk factors, it is very unlikely that chest pain is related to ischemic heart disease. However, after the age of 55 to 60, the rates of CAD in women equal those in men, as the protective effect of menstruation and estrogen fades. 4. Do menstruating women experience myocardial infarctions, heart attacks? Menstruating women rarely experience myocardial infarctions because the protective effects of estrogen are still in place. 5. What is the benefit of exercise for heart health? Regular exercise, even simple activities like taking the stairs instead of the elevator, can significantly improve cardiac health and reduce the risk of heart disease. 6. Is myocardial infarction common in women under 50? Myocardial infarction is very rare in women under 50, which is the average age of menopause. However, this does not mean estrogen replacement therapy is helpful for preventing CAD. 7. Does estrogen replacement therapy help CAD? No. Estrogen replacement may improve LDL, bad cholesterol, levels, but does not help prevent coronary artery disease. 8. Do relaxation methods like yoga, meditation, and Tai Chi improve heart health? There is no measurable evidence that relaxation methods like yoga or meditation improve heart health. While they may help reduce stress, other factors like weight, cholesterol, LDL, and heart rate have measurable effects on heart health. 9. What factors are clearly beneficial for cardiac health? Factors such as weight management, lowering LDL cholesterol, and increasing heart rates through exercise show clear benefits for heart health. General overview. 1. Do women or men have a higher risk of dying from heart disease? Over time, more women will eventually die from heart disease than men. This is because heart disease risk increases as women age, especially after menopause. Risk factors for coronary artery disease, CAD. 2. What are the most clearly agreed upon risk factors for CAD? The main risk factors for CAD are diabetes mellitus, tobacco smoking, hypertension, high blood pressure, hyperlipidemia, high cholesterol, family history of premature CAD, age, over 45 in men and over 55 in women, renal disease, kidney disease. 3. Which risk factor is the worst for CAD? Diabetes mellitus is considered the worst risk factor for CAD. People with diabetes tend to have the highest rates of CAD over a long period of time, e.g., 10 years. 4. Which risk factor is the most common for CAD? Hypertension, high blood pressure, is the most common risk factor for CAD. About 20% of the population, or 60 million people, suffer from hypertension, and nearly half of them don't even know it. Family history and its role in CAD. 5. Does family history affect the risk of CAD? Yes, but it only matters if the family members involved had CAD at a young age, before 55 for men and before 65 for women. The closer the relative, the more important it is. First-degree relatives like parents or siblings. 6. What is considered premature coronary disease in a family member? Premature CAD refers to CAD occurring in male relatives younger than 55 years old, female relatives younger than 65 years old. 7. Does CAD in distant relatives, e.g., grandparents or cousins, affect the patient's risk? No, CAD in distant relatives does not significantly affect the patient's risk. Lipid profile and obesity. 8. Which part of a lipid profile is the most dangerous for CAD risk? Elevated LDL, low-density lipoprotein, is by far the most dangerous part of a lipid profile for CAD. High LDL levels contribute most significantly to the development of coronary artery disease. 9. How important is a low HDL, high-density lipoprotein, in CAD risk? A low HDL is associated with poor long-term prognosis, but it is not as dangerous as having high LDL levels. 10. Are high triglyceride levels a major risk for CAD? Elevated triglycerides are potentially dangerous, but they do not have as strong a correlation with poor outcomes as high LDL levels do. Treating elevated triglycerides is not as beneficial as treating high LDL. 11. How does obesity relate to CAD? Obesity, especially when it causes increased abdominal girth, fat around the belly, is associated with higher cardiac mortality. However, the risks from obesity are often linked to other conditions like diabetes, hypertension, and hyperlipidemia that are more directly harmful to heart health. Less reliable but probable risk factors for CAD. 12. What are some less reliable but probable risk factors for CAD? These factors are not as clearly linked to CAD, but they are still associated with increased risk. Physical inactivity. Lack of exercise can increase the risk of CAD, but not as strongly as other factors like diabetes or hypertension. Excess alcohol consumption. Drinking too much alcohol may contribute to CAD. Insufficient intake of fruits and vegetables. A poor diet can increase the risk of heart disease. Emotional stress. Chronic stress might contribute to heart disease. Elevated cardiac CT scan calcium scores. A calcium score higher than normal on a CT scan of the heart may suggest heart disease, but it's still experimental and not fully understood. 13. Does physical inactivity strongly affect the risk of CAD? Physical inactivity does increase the risk of CAD, but it's not as severe a risk as conditions like diabetes or hypertension. However, regular exercise has clear benefits for reducing heart disease risk. 14. What is the significance of a calcium score from a cardiac CT scan? Calcium scores on a CT scan are still considered experimental. The test may show how much calcium is in the coronary arteries, which can indicate plaque buildup. However, it's not yet clear how to use this information in addition to standard risk factors like blood pressure and cholesterol. Summary of key points. Women are at increasing risk of heart disease, especially as they age. Key risk factors for CAD include diabetes, smoking, hypertension, high cholesterol, family history, and age. Diabetes is the most dangerous risk factor, while hypertension is the most common. Family history matters most when CAD occurs early in a first-degree relative. High LDL cholesterol is the biggest contributor to CAD risk, while low HDL and high triglycerides are less dangerous. Obesity and lack of exercise are contributing factors, but their impact is often secondary to other risk factors. Takotsubo cardiomyopathy. 1. What is Takotsubo cardiomyopathy? Takotsubo cardiomyopathy is a condition where the heart muscle is temporarily weakened and damaged, often following extreme emotional stress. This typically happens in postmenopausal women. 2. What are some common causes of Takotsubo cardiomyopathy? It often occurs after overwhelming emotional stress like divorce, financial problems, natural disasters like earthquakes, traumatic events like lightning strikes, severe low blood sugar, hypoglycemia. 3. What happens to the heart during Takotsubo cardiomyopathy? The left ventricle of the heart undergoes a condition called ballooning, where it temporarily enlarges and doesn't pump properly, leading to left ventricular dyskinesis, impaired movement of the heart muscle. 4. How is Takotsubo cardiomyopathy treated? Treatment includes medications like beta blockers, which help reduce heart strain, and ACE inhibitors, which help lower blood pressure and protect the heart. Revascularization, a procedure to open up blocked arteries, will not help because the coronary arteries are normal in this condition, unlike in other heart diseases like ischemic heart disease. 5. Can emotional stress lead to sudden death? Yes. Extreme emotional stress or anger can lead to chest pain and even sudden death, particularly in cases of Takotsubo cardiomyopathy. Unreliable and proven risk factors for CAD. 6. What are some unreliable or unproven risk factors for coronary artery disease CAD? Some markers that have not proven to be reliable risk factors for CAD include elevated homocysteine levels, chlamydia infection, elevated C-reactive protein levels. These factors have not been shown to have a clear, consistent impact on CAD risk, and measuring or treating these factors is not helpful. 7. Why are some disease markers considered unreliable in CAD risk assessment? These markers, like high homocysteine or elevated C-reactive protein, have been shown to lack consistent evidence linking them to CAD. As a result, there's no benefit in measuring or treating them specifically. 8. What is a common mistake people make when answering CAD risk factor questions? A common mistake is misinterpreting family history. For example, if a patient's elderly relative had CAD, e.g., a mother in her late 60s, people might incorrectly assume it is a significant risk for the patient, even though the relative's age is outside the typical risk range. Smoking and CAD risk. 9. How does smoking affect the risk of CAD? Smoking significantly increases the risk of developing coronary artery disease, CAD. It damages blood vessels and causes plaque buildup in arteries, making the heart work harder. 10. What happens to the risk of CAD after quitting smoking? Smoking cessation leads to immediate improvements in heart health. Within a year, the risk of CAD is reduced by 50%. Within 2 years, the risk is reduced by 90%. 11. What is the greatest immediate improvement in CAD outcomes? The greatest immediate improvement in CAD outcomes is achieved by quitting smoking. Stopping smoking dramatically reduces the risk of developing further heart problems. Summary and key concepts. Takotsubo cardiomyopathy is caused by emotional stress and leads to temporary heart damage, but the coronary arteries are normal, and treatments focus on managing heart function, not revascularization. Unreliable risk factors for CAD include elevated homocysteine, chlamydia, and C-reactive protein, and these should not be the focus of treatment or diagnosis. Family history of CAD is only a risk if it involves premature CAD in first-degree relatives. The biggest impact on CAD outcomes comes from smoking cessation, reducing the risk of heart disease dramatically within the first few years after quitting. Chest pain and ischemic pain. 1. What causes chest pain in general? Chest pain can be caused by various factors, but the heart, as a muscle, causes pain when it doesn't get enough oxygen. This leads to a condition called ischemia, where the heart muscle starts to hurt due to lack of oxygen. Point 2. What does ischemic pain feel like? Ischemic pain is typically dull or sore, squeezing or pressure-like. 3. What type of pain is not ischemic? Pain that is sharp like a knife, point-like, or lasts only a few seconds is not ischemic. Ischemic pain is not tender to the touch. Positional doesn't change with body position. Pleuritic doesn't change with breathing. 4. What are the key features that help tell if chest pain is ischemic or not? Chest pain that changes based on respiration. Pleuritic pain worsens with breathing. Body position, positional pain, changes with movement. Touch of the chest wall, tenderness. These features strongly suggest the pain is not ischemic. 95% of the time, if chest pain changes with these factors, it's not related to the heart. 5. What does a 95% negative predictive value mean? If a feature, like pain changing with respiration, strongly suggests the pain isn't ischemic, it has a 95% chance of being correct. This means 1 in 20 people might still have ischemia, but for exam purposes like the USMLE, it's enough to exclude ischemia. 6. What is the most common non-ischemic cause of chest pain? The most common cause of chest pain, not related to ischemia, is gastrointestinal disorders like heartburn or acid reflux. 7. How common is it for chest pain to be caused by a heart attack, myocardial infarction? Less than 10% of people who come to the emergency department with chest pain actually have a heart attack. For 50% or more, there's no heart disease at all. Characteristics of ischemic pain. 8. What is the duration of ischemic chest pain? Stable angina. The pain lasts more than 2 minutes, but less than 10 minutes. Acute coronary syndrome, ACS, the pain lasts more than 10 minutes, up to 30 minutes. 9. What triggers ischemic chest pain? Ischemic chest pain is usually triggered by physical activity, cold weather, emotional stress. 10. What other symptoms may occur with ischemic chest pain? Symptoms associated with ischemic chest pain include shortness of breath, SOB, nausea, sweating, diaphoresis, dizziness, lightheadedness, fatigue. 11. How would you describe the quality of ischemic chest pain? Ischemic chest pain feels like squeezing, tightness, heaviness, pressure, burning, aching. It does not feel like sharp pins, stabbing, or knife-like pain. 12. Where is ischemic pain usually located? The pain is usually felt substernally, meaning in the chest. 13. What relieves ischemic chest pain? Rest often relieves ischemic chest pain. 14. Where can ischemic pain radiate to? Ischemic pain may radiate to neck, lower jaw, and teeth, arms, shoulders. Causes of chest pain and their diagnosis. 15. What should you do if chest pain is accompanied by chest wall tenderness? If the pain is tender when you touch the chest wall, the most likely diagnosis is costochondritis. The most accurate test is a physical examination. 16. What if chest pain radiates to the back and there is unequal blood pressure between the arms? This could be a sign of aortic dissection. The most accurate test to confirm this is a chest X-ray, which may show a widened mediastinum or a chest CT, MRI, or T, transesophageal echocardiogram. 17. What if chest pain is worse when lying flat and better when sitting up in a young person? This is suggestive of pericarditis, especially in someone under 40. The most accurate test is an electrocardiogram, ECG, which will show ST elevation everywhere and PR depression. 18. What if chest pain is better when eating and associated with epigastric discomfort? This could be duodenal ulcer disease, The most accurate test is endoscopy to examine the stomach and duodenum. 19. What if chest pain is accompanied by a bad taste, cough, or hoarseness? These symptoms are common in gastroesophageal reflux, GERD. The most accurate test is a response to proton pump inhibitors, PPIs, or medications like aluminum hydroxide and magnesium hydroxide, or viscous lidocaine. 20. What if chest pain is associated with cough, sputum, and hemoptysis, coughing up blood? These symptoms point to pneumonia. The most accurate test is a chest X-ray to check for infection in the lungs. 21. What if chest pain is suddenly accompanied by shortness of breath, tachycardia, and hypoxia? This may be a pulmonary embolism. The most accurate tests include a spiral CT or AV/Q scan. 22. What if chest pain is sharp, pleuritic, worsens with breathing, and tracheal deviation is noticed? This could be a pneumothorax, collapsed lung. The most accurate test is a chest X-ray. Summary and key points. Ischemic pain is usually dull, squeezing, and relieved by rest. It doesn't change with body position or touch. Non-ischemic causes of chest pain are often related to gastrointestinal issues, costochondritis, and respiratory conditions. To identify the most accurate diagnosis, you need to consider factors like chest wall tenderness, radiation of pain, and associated symptoms such as shortness of breath or epigastric pain. The appropriate tests vary based on the suspected cause. Features of chest pain that are not helpful for diagnosis. 1. What symptoms are not helpful in determining the cause of chest pain? Certain symptoms are common in many conditions and cannot help identify the cause of chest pain. These include nausea, fever, shortness of breath, dyspnea, sweating, diaphoresis, anxiety. 2. Why is nausea not helpful in diagnosing chest pain? Nausea can happen with many conditions, such as gastrointestinal problems, infections, or stress. It doesn't point directly to heart-related causes of chest pain. 3. Why is fever not helpful in diagnosing chest pain? Fever can occur in conditions like pneumonia or a pulmonary embolism, PE, which may cause chest pain, but fever alone is not specific to heart problems. 4. Why is shortness of breath not always helpful in diagnosing chest pain? Shortness of breath can occur with heart conditions, but it also happens with lung diseases, anxiety, or infections. It is often associated with poor prognosis, especially when combined with chest pain, and needs further investigation. 5. Why is sweating or anxiety not helpful in diagnosing chest pain? Sweating and anxiety can be linked to many causes of chest pain, such as heart issues or stress. However, these symptoms alone don't provide enough information to pinpoint the cause. Diagnostic tests for chest pain. 1. What is the best initial test for chest pain? The best initial test for all forms of chest pain is an electrocardiogram, EKG. This test measures the electrical activity of the heart and helps detect abnormalities that could suggest heart problems. 2. How reliable is the EKG in an office or outpatient setting? In a non-hospital setting like a doctor's office, the EKG is often normal if the patient is not having an active heart attack or other serious heart event. However, it is still important to perform the EKG before moving on to other tests. 3. When are cardiac enzymes like CKMB or troponin used? Cardiac enzymes like CKMB and troponin are most useful when evaluating acute chest pain in an emergency department setting. They help detect if there has been damage to the heart muscle. In chronic or stable chest pain, these tests are not appropriate. If the patient has acute chest pain in the office, the correct response is to transfer them to the emergency department. For what is stress exercise tolerance testing and when is it used? Stress testing is used to evaluate chest pain when the cause is unclear and the EKG isn't diagnostic. It involves having the patient exercise, usually on a treadmill, to increase the heart rate and see if the heart shows signs of ischemia, lack of oxygen. The exercise should get the patient's heart rate above 85% of the maximum, which is calculated as 220 minus the patient's age. 5. How is ischemia detected during a stress test? Ischemia is detected by looking for ST segment depression on the EKG during the stress test. This shows that the heart is not getting enough oxygen during exercise. 6. What should you do if you cannot read the EKG during stress testing? If the baseline EKG is abnormal due to conditions like left bundle branch block or pacemaker use, it can be difficult to detect ischemia. In such cases, you should use other methods such as nuclear isotope uptake using thallium or sestamib, which shows how well the heart is being supplied with oxygen. Echocardiography, which looks for wall motion abnormalities, problems in how the heart's walls move when the heart contracts. 7. How do nuclear isotopes help detect ischemia? Nuclear isotopes like thallium are taken up by normal myocardium, heart muscle, just like potassium is absorbed into cells. If the heart muscle is healthy and well perfused with blood, it will pick up thallium. If there's a problem like ischemia, lack of blood flow, the heart will not absorb thallium properly, showing up as decreased thallium uptake in the imaging. 8. What is the significance of wall motion abnormalities? Wall motion abnormalities, dyskinesis, akinesis, or hypokinesis, mean the heart wall doesn't move correctly. This can be a sign of ischemia or a previous heart attack. Ischemia is reversible, so the wall motion will improve with rest, normalizing after exercise. Infarction, a heart attack, causes permanent damage, so the wall motion abnormalities do not return to normal. 9. What is the difference between ischemia and infarction? Ischemia is a temporary lack of oxygen in the heart muscle, which can be reversed with rest, shown by recovery of wall motion or thallium uptake. Infarction is permanent damage due to a heart attack, where the heart muscle doesn't recover and the abnormalities remain even after rest. 10. What precautions should be taken with stress testing in patients with asthma? Dipyridamole is a medication sometimes used in stress testing, but it can cause bronchospasm, narrowing of the airways. It should be avoided in patients with asthma. EKG. Best initial test for chest pain in any setting. Cardiac enzymes. Used for acute chest pain in the emergency department after performing an EKG. Stress testing. Used when the cause of chest pain is unclear and the EKG is inconclusive. Nuclear isotope uptake or echocardiography. Used when EKG abnormalities prevent proper diagnosis during stress testing. This breakdown covers both the common symptoms of chest pain and the various diagnostic tools used to evaluate it, with specific tips on how to interpret the results depending on the clinical scenario. What to do if the patient cannot exercise. 1. What should be done if the patient cannot exercise for a stress test? If the patient cannot exercise, you need an alternate method to increase their heart's oxygen used to provoke ischemia. This can be done by using medications that mimic the effects of exercise. 2. What are the alternatives to exercise for increasing myocardial oxygen consumption? Two main alternatives are persantine, dipyridamole, or adenosine combined with nuclear isotopes like thallium or sestamib. Dobutamine combined with echocardiography. 3. How does persantine, dipyridamole, or adenosine work? Persantine, dipyridamole, or adenosine increase the heart's oxygen demand by dilating the blood vessels, which mimics the effect of exercise without the patient needing to physically exercise. When combined with nuclear isotopes, like thallium or sestamib, it helps detect areas of the heart that are not getting enough oxygen, ischemia. 4. How does dobutamine work in stress testing? Dobutamine increases the heart's oxygen demand and can provoke ischemia, lack of oxygen. The ischemia can then be detected by looking for wall motion abnormalities on an echocardiogram. This includes dyskinesia, inability of the heart wall to move properly, hypokinesia, reduced motion, or akinesia, complete lack of movement. 5. What are contraindications to using dobutamine for stress testing? Dobutamine should not be used in patients with ventricular arrhythmias, irregular heart rhythms that start in the lower chambers of the heart, severe hypertension, very high blood pressure, left ventricular outflow obstruction, a blockage or narrowing in the heart's main pumping chamber. Patients on beta blockers should temporarily stop taking them before the test. 6. What should be done before administering a dipyridamole stress test? Before giving dipyridamole, it's important to stop caffeine. Caffeine can interfere with the test results because it affects the blood vessels and can mimic the effects of exercise. When reversible ischemia is found on a stress test. 7. What does it mean if a stress test shows reversible ischemia? If the test shows reversible ischemia, it means the heart muscle is not getting enough oxygen during the test, but it can recover when the stress, like exercise or medication, is removed. This suggests that the tissue is still alive and can be saved with treatment, such as revascularization, restoring blood flow to the heart. 8. What should be done if reversible ischemia is found? If reversible ischemia is detected, the next step is to perform angiography, a type of imaging test to look at the heart's blood vessels. This will help determine whether the patient needs bypass surgery, angioplasty, or treatment with medications. 9. Why is angiography important after reversible ischemia is found? Angiography helps doctors see the exact location and severity of blockages in the coronary arteries. The type of revascularization treatment, like bypass or angioplasty, depends on the anatomy of these blockages. Irreversible versus reversible ischemia. 10. What is the difference between reversible and irreversible ischemia? Reversible ischemia means the heart muscle is not getting enough oxygen, but it can recover with proper treatment, like revascularization. Irreversible ischemia, or infarction, means the heart muscle is dead or severely damaged, and no treatment can restore its function. 11. Why isn't revascularization helpful for irreversible ischemia? Irreversible ischemia refers to dead heart tissue, often due to a heart attack. Revascularization won't help because the tissue can't be revived. Revascularization is only useful for reversible ischemia where the heart muscle is still alive and can recover. 12. When should revascularization be done? Revascularization, bypass, or angioplasty should be done when there is reversible ischemia, as it can save the heart tissue and prevent further damage. Nuclear isotopes versus echocardiography for detecting ischemia. 13. How can ischemia be detected using nuclear isotopes or echocardiography? Nuclear isotopes, such as thallium or sestamibi, or echocardiography, are used to detect ischemia when exercise or EKG is not possible or conclusive. Both methods are equally sensitive and specific for detecting ischemia. 14. What is the difference between exercise thallium and exercise echocardiogram? Exercise thallium and exercise echocardiogram are both used to detect ischemia during exercise stress testing. Both methods have the same sensitivity and specificity for detecting ischemia. 15. What is the difference between dipyridamole thallium and dobutamine echocardiogram? Dipyridamole thallium and dobutamine echocardiogram are both used when a patient cannot exercise. They are equally effective for detecting ischemia. Dipyridamole thallium involves using dipyridamole to increase oxygen demand and thallium to track blood flow. Dobutamine echocardiogram uses dobutamine to increase oxygen demand and echocardiography to look for abnormal heart wall movements. Key takeaways. 16. What is the main point about detecting ischemia? The key point is that reversible ischemia suggests that the heart muscle can be saved with revascularization. Irreversible ischemia means the tissue is dead, and there is no point in trying to restore blood flow to that area. 17. What is the importance of angiography after stress testing? After detecting reversible ischemia, angiography is needed to see the exact locations of blockages in the coronary arteries, which will guide treatment decisions like bypass or angioplasty. 18. Why is stopping caffeine important before a dipyridamole test? Caffeine can interfere with the test by affecting the blood vessels, so it's important to stop caffeine before a dipyridamole stress test to get accurate results. What is coronary angiography? 1. What is coronary angiography used for? Coronary angiography is a test used to detect the anatomic location of coronary artery disease, CAD. It helps identify where the arteries in the heart are narrowed or blocked. 2. How does coronary angiography help in treatment decisions? It helps decide whether surgery, angioplasty, a procedure to open blocked arteries, or other revascularization methods are needed to treat CAD. 3. When is angiography used instead of other tests? Angiography is used if non-invasive tests like EKG or stress testing are unclear or inconclusive. Point 4. How accurate is coronary angiography? Angiography is considered the most accurate method for detecting coronary artery disease. 5. What does angiography determine in terms of treatment? It determines whether the patient should have bypass surgery or angioplasty. Stenosis, narrowing, and its significance. 6. What does stenosis mean in coronary artery disease? Stenosis refers to the narrowing of the coronary arteries. It can reduce blood flow to the heart muscle. 7. What is the significance of stenosis less than 50%? Stenosis less than 50% of the artery diameter is considered insignificant and usually does not require surgery or angioplasty. 8. When does coronary artery disease typically require surgery or angioplasty? Surgically correctable disease typically starts with at least 70% stenosis, narrowing of the artery. What is Holter monitoring? 9. What is a Holter monitor? A Holter monitor is a portable EKG device that continuously records the heart's rhythm over a period of 24 to 72 hours. 10. What does a Holter monitor detect? It mainly detects rhythm disorders such as atrial fibrillation, atrial flutter, premature beats, or ventricular tachycardia, abnormal heart rhythms. 11. Does a Holter monitor detect ischemia? No, a Holter monitor does not detect ischemia, reduced blood flow to the heart, and is not used to evaluate the ST segment of an EKG. 12. What is Holter monitoring primarily used for? It is primarily used for evaluating heart rhythm and diagnosing arrhythmias. Diagnostic tests for chest pain. 13. When are enzymes like troponin used in diagnosis? Cardiac enzymes, such as troponin, are used to evaluate acute coronary syndromes, ACS, which are conditions like heart attacks or unstable angina. 14. When are serial troponin measurements done? Serial troponin measurements are taken before a stress test to assess if there has been damage to the heart muscle. 15. What is echocardiography used for? Echocardiography is used to evaluate valve function, how well heart valves work; wall motion, how well the heart's walls are moving during contraction; ejection fraction, the percentage of blood pumped out of the heart with each beat. 16. What is exercise tolerance testing ETT used for? ETT is used to evaluate stable patients with chest pain when the cause is unclear. It is not used in acute coronary syndrome, ACS, cases where the diagnosis is already clear. 17. When should a patient not be put on a treadmill for a stress test? A patient should not be put on a treadmill if they are currently experiencing chest pain, as this may worsen their condition. Treatment for chronic angina. 18. What medications are most concerned with lowering mortality in chronic angina? The most important medications to lower mortality in chronic angina, not acute coronary syndrome, are aspirin, beta blockers. 19. Does USMLE Step 2 CK focus on specific doses of medications? No, the exam focuses on knowing which medications are used, not the specific doses. 20. What form can nitroglycerin be used in chronic angina? Nitroglycerin can be used in forms such as oral, transdermal patch for chronic angina, sublingual, paste, or intravenous forms for acute coronary syndromes. 21. What is the role of antiplatelet therapy in stable CAD? In stable coronary artery disease, CAD, patients usually need aspirin alone unless they have a stent, in which case they may need additional antiplatelet medications. Medications in heart failure and CAD. 22. What is the role of ACE inhibitors/angiotensin receptor blockers, ARBs, in heart failure? ACE inhibitors or ARBs are used in patients with low ejection fraction or systolic dysfunction when the heart doesn't pump blood effectively to reduce mortality. 23. What are the side effects of ACE inhibitors? Cough is the most common side effect of ACE inhibitors, occurring in up to 7% of patients. They can also cause hyperkalemia, high potassium levels. 24. What happens if a patient experiences a cough with ACE inhibitors? If a patient develops a cough with ACE inhibitors, they may be switched to an angiotensin receptor blocker, ARB, but both classes of drugs can cause hyperkalemia. 25. What is hydralazine used for in heart failure? Hydralazine is a direct-acting arterial vasodilator used to decrease afterload resistance the heart has to work against in patients with systolic dysfunction, heart failure. It improves heart function and reduces mortality. 26. How should hydralazine be used in heart failure? Hydralazine should be used with nitrates to dilate coronary arteries and improve blood flow to the heart while reducing afterload. Antiplatelet therapy alternatives. 27. What are the alternatives to aspirin in antiplatelet therapy? Ticagrelor, prasugrel, or clopidogrel can be used as alternatives to aspirin for patients who need additional antiplatelet therapy, especially those with stents. Key takeaways. 28. What is the main focus of treatment in chronic angina? The main goal of treatment in chronic angina is to reduce mortality and prevent heart attacks through medications like aspirin, beta blockers, and ACE inhibitors/ARBs. 29. Why is coronary angiography important? Coronary angiography helps identify the exact location of blockages in the heart's arteries and determines whether surgery or angioplasty is needed to improve blood flow. 30. What role does Holter monitoring play in heart health? Holter monitoring helps diagnose rhythm disorders, but it is not used for detecting ischemia, lack of oxygen to the heart. Beta blockers. 1. What are beta blockers used for in heart disease? Beta blockers are the first-line therapy for stable angina, which is chest pain caused by reduced blood flow to the heart. They are used to help relieve symptoms. 2. How do beta blockers work? Beta blockers work by decreasing the heart's contractility, how hard the heart works, heart rate, and the heart's oxygen demand. This helps the heart use less oxygen, which can reduce chest pain. 3. How does a lower heart rate help in angina? A lower heart rate allows the heart to spend more time in diastole, the phase when the heart is relaxed, which helps improve coronary perfusion, blood flow to the heart muscle. 4. Are all beta blockers equally effective for angina? Yes, all beta blockers are equally effective in treating exertional angina, chest pain triggered by physical activity. 5. Why are non-selective beta blockers rarely used in cardiology? Non-selective beta blockers have more side effects, so they are rarely used in heart-related conditions compared to selective beta blockers. Lipid management. 6. What is the goal for LDL cholesterol in patients with coronary artery disease, CAD? The goal for LDL cholesterol, often called bad cholesterol, in patients with CAD is to keep it below 70 milligrams per deciliter. 7. When should statins be started in primary prevention? Statins should be started in people with a 10-year risk of CAD greater than 7.5% to reduce the risk of heart disease. 8. What are the different types of statins, and how do they affect LDL levels? Statins come in different intensities based on how much they lower LDL. High-intensity statins, e.g., atorvastatin, rosuvastatin, lower LDL by more than 50%. Moderate-intensity statins lower LDL by 30 to 50%. Low-intensity statins lower LDL by less than 30%. 9. What are some examples of statins? Examples of statins include high-intensity, atorvastatin, rosuvastatin. Other statins, fluvastatin, levastatin, pitavastatin, pravastatin, simvastatin. Statin use in various conditions. 10. Which conditions require statins to lower LDL cholesterol? Statins should be used in patients with coronary artery disease, CAD, peripheral artery disease, PAD, carotid artery disease, aortic disease, disease of the aortic artery, stroke, heart attack, MI. 11. What is the main takeaway about statins and lipid management? Statins are the only medication shown to have a definite mortality benefit. They help save lives in managing hyperlipidemia, high cholesterol, in conditions like CAD, stroke, and PAD. Side effects of statins. 12. What are common side effects of statins? Elevated liver enzymes, AST and all, can occur in about 1% of patients. If these levels rise too much, the statin may need to be stopped. Myositis, muscle inflammation, or rhabdomyolysis, severe muscle damage, happens in less than 0.1% of patients. Taking statins. 13. Should CPK, creatine phosphokinase, levels be routinely checked in statin users? No, you don't need to check CPK levels unless the patient has symptoms of muscle pain or weakness. However, AST and ALT levels, liver enzymes, should be routinely checked. Other lipid-lowering therapies. 14. What other drugs are used for lipid management besides statins? Niacin, gemfibrozil, cholestyramine, and ezetimibe can also help improve lipid levels. 15. Why are statins preferred over other lipid-lowering drugs? Statins are preferred because they have a clear mortality benefit in patients with coronary artery disease, CAD, while other drugs do not show the same life-saving benefits. 16. What is niacin used for in lipid management? Niacin can help raise HDL cholesterol, the good cholesterol, and lower LDL and triglycerides. It is often added to statins if full lipid control is not achieved with statins alone. 17. What are the side effects of niacin? Niacin can cause glucose intolerance, higher blood sugar, increased uric acid, can cause gout, an itchy feeling due to the release of prostaglandins. 18. What effect does niacin have on HDL cholesterol? Niacin raises HDL cholesterol more than other treatments like statins and exercise. Indications for statin use. 19. When should statins be used in patients with heart disease or vascular conditions? Statins should be used in patients with acute coronary syndrome, a severe heart problem, heart attack, MI, or after stent placement, any type of arterial disease, a 10-year risk of coronary artery disease greater than 7.5%. Key points about lipid management and statins. 20. What is the key point about lipid management in vascular diseases? The key point is that statins should be used for everyone with vascular disease like CAD, PAD, stroke, to lower LDL cholesterol, as they are the only medications proven to lower mortality. 21. What should be the LDL goal for patients with coronary artery disease? The goal for LDL in patients with CAD is to keep it below 70 milligrams per deciliter to help reduce the risk of heart attacks and improve overall heart health. Gemfibrozil, fibric acid derivatives. 1. What is gemfibrozil used for? Gemfibrozil is a medication used to lower triglycerides, which are fats in the blood. It can reduce triglycerides more effectively than statins, but its overall benefit isn't as great when compared to statins in reducing the risk of death. 2. How does gemfibrozil compare to statins? Statins have a greater benefit in reducing the risk of death than gemfibrozil. Although gemfibrozil can lower triglycerides, lowering triglycerides alone does not have the same proven mortality benefit as statins. 3. What should be considered when combining gemfibrozil with statins? Combining gemfibrozil with statins can increase the risk of myositis, which is muscle inflammation. This is why caution is needed when using both together. 4. Are lipoprotein Q levels or apolipoprotein levels useful for monitoring treatment? No. Checking lipoprotein Q levels, apolipoprotein levels, or LDL particles, types of cholesterol particles, does not provide any benefit when managing lipid levels, cholestyramine, bile acid sequestrants. 5. What is cholestyramine used for? Cholestyramine is a medication that binds bile acids in the gut and helps lower cholesterol levels. It works by preventing cholesterol from being absorbed from the intestines. 6. What are some side effects of cholestyramine? Cholestyramine can cause gastrointestinal discomfort, such as constipation and gas, flatus. 7. What is the interaction of cholestyramine with other medications? Cholestyramine can interfere with the absorption of other medications in the gut, possibly reducing their effectiveness. Ezetimibe. 8. What is ezetimibe used for? Ezetimibe is a medication that helps lower LDL cholesterol levels, which is a type of bad cholesterol in the blood. 9. How does ezetimibe work in lipid management? Ezetimibe lowers LDL levels, but LDL levels are not always the best measure of the effectiveness of cholesterol lowering. Treatments. 10. When should ezetimibe be used in treatment? Ezetimibe should not be the first choice for treating high cholesterol. It should only be used when statins cannot lower LDL to the target levels, such as below 70 or 100 milligrams per deciliter. It can also be used in patients who cannot tolerate statins due to side effects like liver toxicity or muscle inflammation, myositis. PCSK9 inhibitors, evolocumab and alirocumab. 11. What do PCSK9 inhibitors do? PCSK9 inhibitors, such as evolocumab and alirocumab, block the action of PCSK9, a protein that limits the liver's ability to remove LDL cholesterol from the blood. This helps lower LDL cholesterol levels in the bloodstream. 12. How are PCSK9 inhibitors administered? These are injectable medications and are typically used in patients who cannot control their LDL levels with statins alone. 13. What condition is treated with PCSK9 inhibitors? PCSK9 inhibitors are especially useful in treating familial hypercholesterolemia, a genetic condition that leads to very high levels of LDL cholesterol. 14. Do PCSK9 inhibitors lower mortality? Although PCSK9 inhibitors can dramatically lower LDL cholesterol levels, they do not lower mortality, do not reduce the risk of death. 15. Were PCSK9 inhibitors used in treatment? PCSK9 inhibitors are used when a statin is already being taken at its maximum dose, but the LDL cholesterol is still not under control in cases of severe hyperlipidemia, very high cholesterol. Lipid-lowering therapy, key points. 16. What is the main conclusion about lipid-lowering therapies? Statins are the most effective at lowering mortality, saving lives, in patients with high cholesterol, including those with coronary artery disease, CAD, stroke, and peripheral artery disease, PAD. 17. What are some common side effects of lipid-lowering medications? Statins can cause elevations in liver enzymes, AST and ALT, and myositis, muscle inflammation. Niacin can cause elevated glucose, high blood sugar, elevated uric acid, which can lead to gout and itchiness. Pruritus. Fibric acid derivatives like gemfibrozil increase the risk of myositis when combined with statins. Cholestyramine can cause flatus, gas, and abdominal cramping. Ezetimibe is well tolerated, but is considered nearly useless on its own for lowering mortality. Lipid-lowering medications and their adverse effects. 18. What are the adverse effects of statins? Statins can cause elevations in liver enzymes, AST, ALT, and myositis, inflammation of muscles. 19. What are the adverse effects of niacin? Niacin can cause glucose intolerance, higher blood sugar, elevation in uric acid levels, which may lead to gout, and pruritus, itching. 20. What are the adverse effects of fibric acid derivatives, e.g. gemfibrozil? These drugs increase the risk of myositis, muscle inflammation, especially when combined with statins. 21. What are the adverse effects of cholestyramine? Cholestyramine can cause flatus, gas, and abdominal cramping. 22. What are the adverse effects of ezetimibe? Ezetimibe is well tolerated, meaning it has very few side effects. However, it is considered almost useless on its own for lowering cholesterol when compared to statins. Summary of lipid-lowering medications. 23. Which lipid-lowering medication is most effective? Statins are the most effective medication for lowering LDL cholesterol and reducing the risk of death in patients with coronary artery disease, CAD, stroke, and other vascular diseases. 24. Which lipid-lowering drugs have proven mortality benefit? Only statins have a proven mortality benefit. They can reduce the risk of death in patients with high cholesterol or cardiovascular disease. Calcium channel blockers, CCBs. 1. What are calcium channel blockers, CCBs? Calcium channel blockers, CCBs, are medications that block calcium channels in heart and blood vessel cells, leading to relaxation of the muscles around the blood vessels and a decrease in heart rate and force of contraction. This can help treat conditions like high blood pressure and angina. 2. What types of CCBs are mentioned in the text? The text specifically mentions dihydropyridine calcium channel blockers, including nifedipine, nitrendipine, nicardipine, nimodipine. 3. Why are dihydropyridine CCBs like nifedipine not ideal for patients with coronary artery disease, CAD? Dihydropyridine CCBs like nifedipine can increase heart rate, which can worsen the condition in people with coronary artery disease, CAD. This is due to a phenomenon called reflex tachycardia, where the body speeds up the heart rate to compensate for the blood vessel relaxation caused by the medication. 4. What is reflex tachycardia? Reflex tachycardia is when the heart rate increases as a compensatory response to blood vessels relaxing too much, causing a drop in blood pressure. This increase in heart rate can lead to higher oxygen demand by the heart, which can be harmful in CAD. 5. Do CCBs lower mortality in patients with CAD? No. None of the dihydropyridine CCBs have been shown to lower mortality, the risk of death, in patients with coronary artery disease, CAD. In fact, the increased heart rate may increase oxygen consumption, which can be harmful for the heart. 6. What is the bottom line about using CCBs in CAD? Do not routinely use CCBs in patients with CAD unless there are specific indications. Point 7. Which CCBs are safer for use in CAD patients? Verapamil and diltiazem are non-dihydropyridine CCBs that do not increase heart rate and are safer for use in CAD. Patients who cannot tolerate beta blockers due to conditions like asthma. 8. Why are verapamil and diltiazem used in CAD patients who cannot tolerate beta blockers? Verapamil and diltiazem are used in patients who have severe asthma, where beta blockers might worsen the condition by constricting airways. These CCBs do not affect the lungs in the same way. 9. Can patients with reactive airway diseases like asthma tolerate beta blockers? Yes, most patients with reactive airway diseases like asthma can tolerate beta-1 specific beta blockers, which primarily affect the heart and have less impact on the lungs. 10. When should CCBs, verapamil/diltiazem, be used in CAD? CCBs like verapamil and diltiazem should be used in CAD in the following situations. 1. Severe asthma that precludes the use of beta blockers. 2. Prinzmetal variant angina, a type of angina caused by spasm of the coronary arteries. 3. Cocaine-induced chest pain, because beta blockers are thought to be contraindicated in this condition. 4. Inability to control pain with maximum medical therapy. Adverse effects of CCBs. 11. What are the common adverse effects of CCBs? The most common side effects of CCBs are 1. Edema, swelling, particularly in the lower legs. 2. Constipation, especially with verapamil. 3. Heart block, rare, but it involves problems with the electrical conduction in the heart. 12. Why is it important to know the adverse effects of CCBs? Knowing the adverse effects is critical for proper patient care, especially since questions in exams like USMLE Step 2 CK often focus on these side effects. Ranolazine. 13. What is ranolazine used for? Ranolazine is a sodium channel blocker used to treat angina, chest pain. It is added when patients continue to experience pain despite other treatments like aspirin, beta blockers, nitrates, and calcium channel blockers. 14. Does ranolazine have a clear benefit in reducing mortality? No. Ranolazine does not have a clear mortality benefit, meaning it doesn't significantly reduce the risk of death. 15. When is ranolazine used in treatment? Ranolazine is used in patients who still experience angina despite taking other medications or when revascularization, like stenting or bypass surgery, is not an option or is not effective. Summary and key takeaways. 16. What is the main takeaway about using CCBs in CAD? Dihydropyridine CCBs like nifedipine should not be used routinely in coronary artery disease, CAD, because they increase heart rate, which can worsen the condition. 17. Which CCBs are safer in CAD patients? Verapamil and diltiazem are safer options because they do not increase heart rate and can be used in patients who cannot tolerate beta blockers. 18. What is the role of ranolazine in treating angina? Ranolazine is added for patients whose angina isn't controlled with other treatments. However, it does not reduce the risk of death. 19. What are the adverse effects of ranolazine? While not mentioned in the text, ranolazine can cause some common side effects such as dizziness, nausea, and constipation, though these are generally less severe than those of other medications. Revascularization overview. 1. What is revascularization? Revascularization is a medical procedure to restore blood flow to the heart by either coronary bypass surgery (CABG) or angioplasty, also called percutaneous coronary intervention (PCI). 2. Why is angiography important in evaluating revascularization? Angiography is a test that visualizes the blood vessels of the heart. It's necessary to know things like the number of vessels involved, which specific vessels are narrowed, stenosed, and the degree of narrowing. Symptoms alone cannot provide this information. 3. What is the role of angioplasty and coronary bypass surgery (CABG) in heart disease? Both angioplasty and CABG are used to treat severe coronary artery disease by restoring blood flow to the heart. They are options when medication alone is not enough to control symptoms or prevent heart problems. Coronary artery bypass grafting (CABG). 4. When does coronary artery bypass grafting (CABG) lower mortality? CABG reduces mortality in patients with very severe coronary artery disease (CAD), specifically in the following cases. 1. 3 vessels with at least 70% stenosis in each vessel. 2. Left main coronary artery occlusion, complete blockage. 3. 2-vessel disease in a patient with diabetes. 4. Persistent symptoms despite the best medical therapy. 5. What is the benefit of CABG for long-term survival? The long-term survival benefit of CABG is most noticeable in people with severe disease, such as those with left ventricular dysfunction, when the heart's pumping ability is weakened. 6. What is the risk of CABG for patients with an ejection fraction (EF) below 35%? Patients with an ejection fraction (EF) below 35%, meaning their heart is pumping poorly, may have greater immediate operative mortality, risk of death during surgery. However, if they survive the surgery, their survival improves in the long term, especially if they have 3-vessel disease. 7. How long do the grafts used in CABG last? The internal mammary artery grafts used in CABG tend to last around 10 years before they may become blocked. Occlude. Saphenous vein grafts are less durable, lasting about 5 years, and half of vein grafts are no longer open patent after 10 years. Percutaneous coronary intervention (PCI). 8. What is percutaneous coronary intervention (PCI)? PCI, often called angioplasty, is a procedure to open blocked coronary arteries. It involves inserting a balloon or stent into the artery to widen it. Intervention refers to different procedures within PCI, including angioplasty. 9. When is PCI particularly beneficial? PCI is very effective in treating acute coronary syndromes, especially when there is ST segment elevation, which indicates a serious heart attack. 10. Does PCI improve survival in chronic stable angina? For stable coronary artery disease (CAD), PCI does not show a clear survival benefit compared to maximal medical therapy. Medications like aspirin, beta blockers, ACE inhibitors, ASAs, angiotensin receptor blockers, ARBs, and statins can provide equal or even superior benefit in preventing heart attacks and managing symptoms. 11. What benefits does PCI provide for stable CAD? PCI is better at reducing dependence on medications and reducing the frequency of angina attacks, chest pain. It can make patients feel better and reduce the need for frequent treatment adjustments. Point 12. What is the main benefit of PCI in acute coronary syndromes? PCI is the best treatment for acute coronary syndromes, especially when there is ST segment elevation on an ECG, indicating a severe heart attack. 13. Does PCI reduce mortality in stable CAD patients? No, PCI does not provide a clear mortality benefit for patients with stable coronary artery disease (CAD). Medication therapy has been shown to work just as well or better for managing these patients long-term. Key takeaways. 14. When should CAB be considered for a patient? CAB should be considered in patients with severe coronary artery disease, such as 3-vessel disease, left main, artery blockage, or diabetes with 2-vessel disease, or in those who continue to have symptoms despite maximal. Medical therapy. 15. What is the role of angiography in deciding treatment for heart disease? Angiography is essential in evaluating heart disease because it helps doctors understand the extent and location of blockages in the coronary arteries, which helps guide decisions about revascularization. 16. What is the long-term prognosis for patients who undergo CAB with severe disease? Patients who have severe disease, like 3-vessel disease, and undergo CAB can experience improved long-term survival, particularly if their heart function is significantly weakened, low ejection fraction. 17. How does PCI help in acute coronary syndromes? In acute coronary syndromes, PCI quickly opens blocked arteries, which can reduce the extent of heart damage during a heart attack and improve survival in the short term. Acute coronary syndromes, ACS. 1. What are acute coronary syndromes, ACS? Acute coronary syndromes, ACS, are a group of conditions that involve a sudden reduction in blood flow to the heart, often due to blockages in the coronary arteries, leading to chest pain or discomfort. The conditions under ACS include unstable angina, non-ST elevation myocardial infarction, and STEMI, and ST elevation myocardial infarction, STEMI. 2. Can the history and physical exam alone determine the cause of ACS? No, the precise cause of ACS cannot be determined from history and physical exam alone. Further diagnostic tests like EKG and blood markers are needed to confirm the diagnosis. 3. What risk factors are associated with ACS? The risk factors for ACS are the same as those for coronary artery disease, CAD, hypertension, high blood pressure, diabetes mellitus, tobacco use, smoking. 4. What is an S4 gallop and why is it associated with ACS? An S4 gallop is an extra heart sound caused by atrial contraction when blood is forced into a stiff, non-compliant ventricle. In ACS, the heart muscle may become stiff due to ischemia, making this sound more likely. 5. What is pulsus paradoxus, and what condition is it associated with? Pulsus paradoxus is a drop in blood pressure of more than 10 millimeters of mercury when a person inhales. It is often associated with cardiac tamponade, a condition where fluid builds up around the heart and affects its ability to pump effectively. 6. What is the Kussmaul sign, and what conditions is it linked to? The Kussmaul sign is an increase in jugular venous pressure during inhalation. It's seen in conditions like constrictive pericarditis or restrictive cardiomyopathy, where the heart's filling is restricted. 7. What is a pericardial friction rub? A pericardial friction rub is a scratchy, triphasic sound heard when the heart's outer lining, the pericardium, rubs against the heart. It can occur in pericarditis, which may develop after a heart attack, Dressler syndrome, but it typically appears days later and is rarer than ventricular ischemia. 8. What is a continuous machinery murmur, and what does it indicate? A machinery murmur is a continuous, gurgling sound heard with a patent ductus arteriosus, a heart condition where a blood vessel fails to close after birth. 9. What is a displaced point of maximal impulse, PMI, and what does it indicate? A displaced PMI is when the point where the heart's beat is felt shifts from its normal position. This is commonly seen in conditions like left ventricular hypertrophy, LVH, or dilated cardiomyopathy. It's not associated with ACS. 10. Can physical findings alone diagnose ACS? No, there are no specific physical findings that allow a most likely diagnosis of ACS based solely on things like ST elevation or depression. An EKG is essential to diagnose ACS accurately. 11. What does ST elevation in leads V2 to V4 indicate? ST elevation in leads V2 to V4 usually indicates an acute myocardial infarction, MI, in the anterior wall of the heart, often a serious condition. 12. What does ST elevation in leads 2, 3, and AVF indicate? ST elevation in leads 2, 3, and AVF indicates an acute myocardial infarction, MI, in the inferior wall of the heart. While serious, the mortality rate for an inferior wall MI is usually less than 5% after 1 year if untreated. 13. What is the mortality rate for anterior wall MI, AWMI, if untreated? For anterior wall myocardial infarction, AWMI, untreated, the mortality rate is much higher, around 30% to 40%. 14. What is first-degree AV block, and is it serious? A PR interval greater than 200 milliseconds is known as first-degree atrioventricular, AV block. This condition has little pathologic potential and does not require additional treatment if isolated. 15. Are ectopic beats, like PVCs or APCs, dangerous in ACS? Premature ventricular contractions, PVCs, and atrial premature complexes, APCs, are common in ACS but are not life-threatening on their own. They don't require additional treatment if magnesium and potassium levels are normal. These ectopic beats may lead to more severe arrhythmias later, but immediate treatment isn't needed. 16. What does ST depression in leads V1 and V2 suggest? ST depression in leads V1 and V2 suggests a posterior wall myocardial infarction, MI. This type of infarction is associated with lower mortality and doesn't require additional therapy. 17. What is the significance of a right bundle branch block, RBBB, in ACS? RBBB, right bundle branch block, is usually benign and doesn't require treatment. However, a new left bundle branch block, LBBB, is more concerning and may indicate a more severe heart issue. 18. Should PVCs be treated during an acute MI? No. PVCs, premature ventricular contractions, should not be treated, even during an acute myocardial infarction, MI. Treating PVCs during an MI can worsen the outcome. 19. What role does aspirin play in treating ACS? Aspirin lowers mortality in ACS and should be administered as soon as possible. It is essential to give aspirin immediately, even before catheterization or thrombolytic therapy. 20. How soon should aspirin be given in ACS? Aspirin should be given within the first hour of chest pain onset. At this point, CCAM-B and troponin levels would not be elevated yet. 21. Does morphine, oxygen, and nitroglycerin reduce mortality in ACS? Morphine, oxygen, and nitroglycerin are important for symptom management in ACS, but they do not lower mortality as much as aspirin. Therefore, aspirin should be prioritized. 22. Should oxygen be given to all ACS patients? Oxygen is not necessary for all ACS patients, particularly if they are not hypoxic, have normal oxygen levels in their blood. 23. What additional medications should be given to patients with an acute MI? In addition to aspirin, clopidogrel, prasugrel, or ticagrelor should be given to any patient with an acute myocardial infarction, MI, to further reduce the risk of clot formation. 24. Where should ACS patients be transferred after initial treatment? After starting therapy, the patient should be transferred to an intensive care unit, ICU, for further monitoring and treatment. Immediate care is more important than simply moving the patient. 25. What is the priority in ACS management? In ACS, the priority is starting treatment quickly, such as giving aspirin, before worrying about transferring the patient to other areas of the hospital. 26. When should thrombolytics or angioplasty be performed in ACS? Thrombolytics, clot-dissolving drugs, or angioplasty, mechanical opening of the artery, should be performed as quickly as possible in ACS patients to restore blood flow to the heart. 27. What is the key to preparing for ACS management on exams like USMLE Step 2 CK? On exams, it's essential to know the order of treatments and prioritize them. Simply knowing the treatments is not enough. You need to know what to do first in each situation. Summary. Aspirin is the most important treatment for acute coronary syndromes, ACS, because it lowers mortality. Thrombolytics or angioplasty should follow. Oxygen, morphine, and nitroglycerin help with symptoms, but do not significantly lower Mortality. Fast, decisive action is critical. General concepts. Q1. What is angioplasty and how is it related to mortality benefit in acute coronary syndrome, ACS? 1. Angioplasty is a procedure used to open blocked coronary arteries, and it provides the greatest mortality benefit in managing acute coronary syndromes. While other treatments may be helpful, angioplasty directly addresses the blockage causing the heart problem, significantly improving survival rates. Q2. What is the role of nitrates in the treatment of ACS? 2. Nitrates are given to ACS patients to relax and widen the blood vessels, helping to reduce the heart's workload. However, they don't have a clear effect on mortality, meaning they help with symptoms but don't directly save lives in the same way that angioplasty does. Q3. When should enzyme tests be done in ACS management? 3. Enzyme tests, such as CCAM-B and troponin, should be done to assess heart damage. However, these tests will be normal in the first 4 hours of chest pain onset. If elevated, they won't change how the patient is managed. Q4. How do beta blockers contribute to the treatment of ACS? 4. Beta blockers lower mortality in ACS by slowing the heart rate and reducing the heart's oxygen demand. They're most beneficial when given during the hospital stay and at discharge, though their timing is not critical. Q5. What is the role of statins and ACE inhibitors in ACS? 5. Statins and ACE inhibitors also lower mortality in ACS patients, but like beta blockers, they are most important when given during the hospital stay and at discharge, and they don't need to be started immediately. Diagnostic tests. Q6. What is the importance of EKG in diagnosing ACS? 6. An EKG, electrocardiogram, is crucial for diagnosing ACS because it shows changes like ST elevation that indicate heart damage. These changes appear immediately with pain and progress over several days. Q7. How soon do enzyme levels become abnormal in ACS? 7. Myoglobin. Abnormal in 1 to 4 hours and lasts for 1 to 2 days. CCAM-B. Abnormal in 4 to 6 hours and lasts for 1 to 2 days. Troponin. Abnormal in 4 to 6 hours and lasts for 10 to 14 days. Q8. Why is troponin used in ACS diagnosis, and what are its limitations? 8. Troponin is a protein released when heart muscle is damaged, making it useful in diagnosing heart attacks. However, it can't distinguish a new heart attack from a reinfarction, and in patients with kidney problems, it may give false positive results. Reinfarction. Q9. How do you diagnose a reinfarction in ACS patients? 9. 1. Perform an EKG to check for new ST segment changes. 2. Measure CCAM-B levels. If CCAM-B is elevated several days after the initial heart attack, it suggests a new ischemic event. Q10. Why is CCAM-B important for detecting reinfarction? 10. CCAM-B levels rise during a heart attack and return to normal in 1 to 2 days. If CCAM-B is elevated after the first few days, it indicates a new heart problem, such as a reinfarction. Intensive care unit, ICU monitoring. Q11. Why is ICU monitoring critical for ACS patients? 11. ICU monitoring is important because it allows continuous observation of heart rhythm, helping to detect and treat dangerous arrhythmias like ventricular tachycardia or fibrillation, which are the most common cause of death in the first few days after a heart attack. Q12. What tests are important in the ICU to monitor for reinfarction? 12. Continuous monitoring of CCAM-B levels is important in the ICU. Elevated levels after 24 to 48 hours indicate a reinfarction. Medications in ACS. Q13. What medications should be given to ACS patients immediately? 13. Aspirin should be given immediately to all ACS patients because it helps reduce blood clotting and lowers mortality. Clopidogrel, often used if the patient is allergic to aspirin. Prasugrel or ticagrelor, alternatives to clopidogrel, especially useful when a coronary stent is placed. Q14. Why is it important to use 2 antiplatelet drugs in ACS? 14. Using 2 antiplatelet drugs, Aspirin and one of clopidogrel, prasugrel, or ticagrelor provides better protection against blood clots during an acute coronary event and when a coronary stent is placed. Q15. Which antiplatelet medication is preferred when angioplasty and stenting are planned? A 15. Prasugrel or ticagrelor are preferred because they are more effective at preventing the re-narrowing of arteries after stenting. Q16. What is the role of clopidogrel in ACS management? A 16. Clopidogrel is used in combination with aspirin for all ACS patients. It is also used for patients who are intolerant to aspirin. It is used after angioplasty with stenting, and it provides benefits in chronic angina. Q17. What are the risks of clopidogrel? A 17. Clopidogrel is rarely associated with thrombotic thrombocytopenic purpura, TTP, a serious condition that causes blood clotting problems. Q18. What is prasugrel used for in ACS treatment? A 18. Prasugrel is used for ACS patients who are undergoing angioplasty and stenting. It is especially beneficial in reducing the risk of blood clots, but should be avoided in patients older than 75 due to an increased risk of hemorrhagic stroke. Q19. When is ticlopidine used? A 19. Ticlopidine is used in patients who cannot tolerate aspirin or clopidogrel, but it has risks like neutropenia, low white blood cell count, and TTP, which limit its use. Q1. What is angioplasty PCI, and how is it different from thrombolytics in terms of survival and complications? A 1. Angioplasty PCI is a procedure to open blocked coronary arteries, and it is superior to thrombolytics, clot-busting drugs, in several ways. It provides a better survival rate and reduces mortality. It has fewer complications like bleeding. It leads to fewer serious heart problems like arrhythmias, congestive heart failure, and heart muscle rupture. Angioplasty also has a quicker recovery from complications compared to thrombolytics. Q2. What is door-to-balloon time and why is it important? A 2. Door-to-balloon time refers to the time between a patient arriving at the hospital and having angioplasty performed. The standard of care is to complete this within 90 minutes, as a shorter time frame is associated with better outcomes. Complications of angioplasty, PCI. Q3. What are the potential complications of angioplasty? A 3. The complications of angioplasty include 1. Rupture of the coronary artery when the balloon is inflated. 2. Restenosis, the artery becoming blocked again due to blood clots forming after the angioplasty. 3. Hematoma, blood pooling at the entry site like in the femoral area. 4. Distal cholesterol embolization, which can cause a rash called livedo reticularis and may lead to issues like eosinophilia. High eosinophils in blood, eosinophiluria, eosinophils in urine, low complement, and a high ESR. There is no specific treatment for distal cholesterol embolization. Q4. Why are only 20% of U.S. hospitals equipped to perform primary angioplasty? A 4. Many hospitals do not have a catheterization laboratory, the specialized equipment needed to perform angioplasty, or the ability to perform emergency cardiac surgery, which is crucial in case of complications like vessel rupture during the procedure. Drug-eluting stents. Q5. What are drug-eluting stents and how do they help in reducing restenosis? A 5. Drug-eluting stents are stents coated with medication that helps prevent the growth of tissue around the stent, reducing the chances of the artery becoming blocked again, restenosis. This is much more effective than non-drug-coated stents. Q6. How is heparin used in angioplasty, and is it continued long-term? A 6. Heparin is used during the angioplasty procedure to prevent blood clotting. However, it is not used long-term after the procedure. Q7. What is the role of warfarin in coronary disease? A 7. Warfarin is not used in coronary artery disease management. It is a blood thinner used for clot prevention in venous problems, like deep vein thrombosis, DVT, or pulmonary embolism, but it doesn't help in coronary artery disease. Rates of restenosis after PCI. Q8. What are the rates of restenosis, re-narrowing of the artery, after PCI based on the type of stent used? 8. Without a stent, 30% to 40% chance of restenosis. Bare metal stent, 10% to 15% chance. Drug-eluting stent, less than 5% chance. Contraindications to thrombolytics. Q9. What are the contraindications to using thrombolytics in ACS patients? A 9. Thrombolytics should not be used if 1. The patient has major bleeding in areas like the bowel or brain. 2. The patient has had recent surgery within the last 2 weeks. 3. The patient has very high blood pressure, above 180/110 mmHg. 4. The patient had a non-hemorrhagic stroke in the past 6 months. However, having blood in stool, even if it's brown, is not a strict contraindication. Time sensitivity of treatment. Q10. Why is timing critical in the treatment of ACS? A 10. Time is muscle means that the quicker you treat a heart attack, the less heart muscle is damaged. Thrombolytics have a mortality benefit if given within the first 12 hours of chest pain onset. The benefit is greatest in the first 2 hours, with a 50% reduction in relative risk of death. Q11. What is door-to-needle time, and why is it important? 11. Door-to-needle time refers to the time it takes to give thrombolytics, clot-busting drugs, after a patient arrives at the hospital. It should be under 30 minutes to maximize the benefit. Treatment indications and benefits. Q12. When should aspirin be given to an ACS patient? A 12. Aspirin is the best initial therapy for everyone with ACS because it helps prevent blood clots and improves outcomes. Q13. When is clopidogrel, prasugrel, or ticagrelor are used? A 13. These medications are used alongside aspirin in patients undergoing angioplasty or stenting. They help prevent further clots from forming during and after the procedure. Q14. What is the role of beta blockers in ACS? A 14. Beta blockers should be given to everyone with ACS. They help reduce the heart's workload and decrease the risk of arrhythmias, but they don't need to be given at a specific time and can be started anytime during the hospital stay. Q15. When should ACE inhibitors or ARBs be used in ACS? A 15. ACE inhibitors or ARBs are recommended for all patients, but they are especially beneficial if the patient's heart function is impaired, ejection fraction below 40%. Q16. What is the role of statins in ACS? A 16. Statins should be used for everyone with ACS to lower cholesterol. The goal is to reduce LDL, bad cholesterol, to below 70 mg/dl to prevent further complications. Q17. What is the role of nitrates in ACS treatment? A 17. Nitrates help reduce chest pain by relaxing blood vessels, but they do not have a clear benefit in terms of reducing mortality. Q18. When is heparin used in ACS treatment? 18. Heparin is used after thrombolytics or PCI to prevent restenosis, the artery becoming blocked again, and to treat non-ST elevation events like unstable angina. Q19. When are calcium channel blockers used in ACS treatment? A 19. Calcium channel blockers are used when beta blockers cannot be used, such as in patients with cocaine-induced pain or in cases of Prinzmetal or vasospastic angina, which are types of chest pain related to artery spasm. Q1. What is the role of low molecular weight, LMW, heparin in treating coronary artery disease? A 1. LMW heparin helps prevent new clots from forming in the coronary arteries. It does not dissolve clots that have already formed, but it prevents them from getting bigger or causing further blockages. Q2. Is thrombolytic therapy beneficial in all types of acute coronary syndrome, ACS? A 2. No, thrombolytic therapy is not beneficial in non-ST elevation ACS, like unstable angina or non-ST elevation myocardial infarction MI. It is only useful in ST elevation MI, where there is a blockage causing the heart muscle to die. Q3. What is the role of nitroglycerin, morphine, and oxygen in ACS treatment? A 3. While nitroglycerin, morphine, and oxygen help relieve symptoms, they do not reduce mortality or improve survival in ACS patients. They are primarily used to manage pain and improve comfort. Q4. When should ACE inhibitors and statins be used in ACS patients? 4. ACE inhibitors are used in patients with low heart function, low ejection fraction, while statins are used to lower high cholesterol, high LDL. These treatments help prevent further heart problems, but their main benefit depends on specific conditions like low ejection fraction or high LDL. Q5. How urgent is it to give beta blockers like metoprolol in ACS? 5. There is no urgency to give beta blockers immediately in ACS. It's important to give them at any time before discharge, but it does not need to be within the first few hours or minutes of the hospital stay. Q6. Why is heparin given urgently in ACS? 6. Heparin is given urgently because it prevents the clot from growing and blocking the coronary artery further. This reduces the risk of more damage to the heart muscle. Glycoprotein IB/3A inhibitors. Q7. What are glycoprotein IB/3A inhibitors? Abciximab, tirofiban, eptifibatide. And when are they used? 7. These are drugs that prevent platelets from sticking together, which helps to prevent further clot formation. They are used in ACS patients who are undergoing angioplasty and stenting, but are not effective in ST elevation MI without angioplasty. Q8. How do glycoprotein IB/3A inhibitors help in non-ST elevation ACS? 8. In non-ST elevation ACS, these inhibitors reduce the risk of death, especially in patients whose troponin or CKMB levels rise, and who later require angioplasty with stenting. Contraindications to thrombolytics. Q9. What are the absolute contraindications for using thrombolytics in ACS? 9. Thrombolytics should not be used if 1. There is major bleeding, e.g., in the bowel or brain. 2. The patient has had recent surgery within 2 weeks. 3. The patient has severe hypertension above 180/110. 4. The patient had a non-hemorrhagic stroke within the last 6 months. Treatment guidelines for different cardiac events. Q10. What treatments are used in stable angina, unstable angina, and MI, ST elevation, and non-ST elevation? 10. Aspirin. Used in all conditions, stable angina, unstable angina, and MI. Beta blockers. Used in all conditions to reduce heart workload. Nitrates. Used in all conditions to relieve pain by dilating blood vessels. Morphine. Used to relieve pain in angina and MI, but it doesn't improve survival. Treatment bottom line for different ACS types. Q11. What is the best treatment for ST elevation MI STEMI? 11. Thrombolytics, TPA, are most beneficial in STEMI as they help dissolve the clot causing the heart attack. Q12. What is the best treatment for non-ST elevation MI in STEMI? 12. Low molecular weight heparin, LMW heparin, is the best treatment for STEMI to prevent clot formation and progression. Q13. When are glycoprotein IB/3A inhibitors most beneficial? 13. Glycoprotein IB/3A inhibitors are most beneficial for STEMI patients who are undergoing angioplasty and stenting to prevent clotting during the procedure. Medications without mortality benefit in ACS. Q14. Do calcium channel blockers and warfarin help reduce mortality in ACS? 14. No. Calcium channel blockers and warfarin do not provide any mortality benefit in ACS. Warfarin is used for blood clots in the veins, not in the arteries, and calcium channel blockers don't improve survival in ACS. Q15. What is the difference between low molecular weight heparin and unfractionated heparin? 15. Low molecular weight heparin, enoxaparin, is superior to unfractionated heparin in terms of reducing mortality in ACS, as it is more predictable and easier to use. Urgent procedures for non-ST elevation ACS. Q16. What should be done if a patient with non-ST elevation ACS does not improve with medication? 16. If the patient's condition does not improve after medication, and they continue to experience symptoms like pain or develop new heart problems, e.g., heart failure or abnormal heart rhythms, urgent angiography and possibly angioplasty should be performed to open the blocked arteries. Q17. What are signs that the patient with non-ST elevation ACS needs urgent intervention? 17. Signs include 1. Persistent chest pain despite treatment. 2. S3 gallop or congestive heart failure, CHF, symptoms. 3. Worsening EKG changes or sustained ventricular tachycardia. 4. Rising troponin levels, indicating ongoing heart muscle damage. Complications of myocardial infarction. Q18. What are the complications of a myocardial infarction, MI? 18. Complications of MI include problems like hypotension, low blood pressure, ventricular tachycardia, heart failure, or other heart rhythm issues. These complications can result in life-threatening conditions, and early treatment is necessary to prevent worsening. Q19. Why is hypotension not a helpful sign in diagnosing MI complications? 19. Hypotension is a common symptom of many MI complications, so it alone cannot help determine the exact problem. A. Thorough evaluation is necessary to identify the specific complication. This detailed breakdown explains the treatment options, benefits, and considerations for managing acute coronary syndromes, ACS, emphasizing when specific medications and interventions should be used. It also explains the importance of timely treatment to prevent worsening outcomes in patients with ACS, tachycardia, and right ventricular infarction, RV infarction. Q7. How do you identify right ventricular infarction? 7. Right ventricular infarction is associated with a new inferior wall MI, clear lungs, and symptoms like hypotension or tachycardia. It can be diagnosed by flipping the EKG leads to the right side of the chest, where ST elevation in RV4 is the most specific finding. Q8. What is the role of the right coronary artery in right ventricular infarction? 8. The right coronary artery supplies the right ventricle, the AV node, and the inferior wall of the heart. An inferior wall MI can cause damage to the right ventricle, leading to RV infarction. Q9. How should right ventricular infarction be treated? 9. Right ventricular infarction is treated with high-volume fluid replacement to improve blood flow to the heart. Nitroglycerin should be avoided because it can worsen cardiac filling and low blood pressure in RV infarction tamponade and free wall rupture. Q10. What is cardiac tamponade, and how does it occur after MI? 10. Cardiac tamponade occurs when fluid accumulates in the pericardial sac around the heart, leading to pressure on the heart and impaired heart function. It usually happens several days after an infarction when the heart wall weakens enough to rupture. Q11. How do you diagnose tamponade or wall rupture? 11. Cardiac tamponade is suspected when there is sudden loss of pulse and jugulovenous distension, neck vein engorgement. Diagnosis can be confirmed with emergency echocardiography. Q12. What is the treatment for tamponade or wall rupture? 12. Emergency pericardiocentesis, draining fluid from the pericardial sac, is performed to relieve the pressure, and then the patient is taken to the operating room for surgical repair. Ventricular tachycardia and ventricular fibrillation. Q13. What are ventricular tachycardia, VT, and ventricular fibrillation, VF, and how are they treated? 13. Both VT and VF are abnormal heart rhythms that can lead to sudden death. They cause loss of pulse and require emergency electrical shock, cardioversion, or defibrillation to restore normal heart rhythm. Valve or septal rupture. Q14. What are the signs of valve or septal rupture after an MI? 14. Both valve rupture and septal rupture present with a new heart murmur and pulmonary congestion, fluid in the lungs. The murmur from mitral regurgitation is best heard at the apex of the heart, and the murmur for ventricular septal rupture is best heard at the lower left sternal border. Q15. What is the most accurate test to diagnose valve rupture and septal rupture? 15. The most accurate test for both valve rupture and septal rupture is echocardiography. Q16. How do you diagnose septal rupture using oxygen saturation? 16. A step up in oxygen saturation from the right atrium to the right ventricle can confirm septal rupture. This occurs because blood from the left side of the heart, which is oxygenated, mixes with blood from the right side, which is less oxygenated, due to the hole in the septum. Intra-aortic balloon pump, IABP. Q17. What is the role of an intra-aortic balloon pump, IABP? A17. The IABP is used to support the heart in cases of acute pump failure caused by an anatomical problem, like a valve issue. It works by inflating and deflating in sync with the heart's natural rhythm, helping to improve blood flow. Q18. Is the IABP a permanent solution? 18. No, the IABP is a temporary device. It is used as a bridge to surgery for valve replacement or heart transplant, typically for 24 to 48 hours. Extension of the infarction or reinfarction. Q19. What are the signs of a reinfarction or extension of a heart attack? A 19. Signs of a reinfarction include recurrence of chest pain, new rales, crackling lung sounds, rising CKMB levels, a marker of heart muscle damage, and pulmonary edema, fluid in the lungs. These signs suggest that another area of the heart is being damaged. Q20. How do you manage a reinfarction? A 20. For a reinfarction, a repeat EKG should be performed, and the patient may need additional treatments like angioplasty and thrombolytics, along with medications like aspirin, metoprolol, nitrates, ACE inhibitors, and statins. Aneurysm and mural thrombus. Q21. How are aneurysms and mural thrombi detected after a heart attack? A 21. Aneurysms and mural thrombi can be detected with echocardiography. Most aneurysms do not require specific therapy, but mural thrombi are treated with heparin followed by warfarin to prevent blood clots, key features for diagnosis of cardiac complications. Q22. What key feature distinguishes third-degree AV block? A 22. The key feature of third-degree AV block is the presence of canon A waves, large, forceful jugular venous pulses. Q23. How do you differentiate sinus bradycardia from third-degree AV block? A 23. Sinus bradycardia does not have canon A waves, while third-degree AV block does. Q24. What is the key feature of tamponade or wall rupture? A 24. The key feature is a sudden loss of pulse and jugulovenous distension, engorgement of neck veins. Q25. How do you identify RV infarction? A 25. RV infarction is identified by a history of inferior wall MI, clear lungs, and findings like tachycardia or hypotension, especially after the use of nitroglycerin. Q26. How is valve rupture or septal rupture diagnosed? A 26. Valve rupture is diagnosed by a new murmur and pulmonary congestion, while septal rupture is diagnosed by a step-up in oxygen saturation from the right atrium to the right ventricle. Q27. What is the diagnostic feature of ventricular fibrillation? A 27. The diagnostic feature of ventricular fibrillation is the loss of pulse, and an EKG is needed to distinguish it from other causes of cardiac arrest. Preparation for discharge from hospital. Q1. When should you avoid performing a stress test on a patient post-MI, myocardial infarction? A 1. A stress test should not be performed if the patient remains symptomatic because they likely need an angiogram to check for blockages or coronary artery disease. Q2. When is angiography unnecessary in a post-MI patient? A 2. Angiography is unnecessary if there are no reversible signs of myocardial ischemia, meaning there is no blood supply issue that can be treated through angioplasty or stent placement. There is no benefit to revascularizing, restoring blood flow to heart muscle that is already dead due to infarction. Q3. Why is dipyridamole not the right choice for coronary artery disease, CAD? A 3. Dipyridamole is not recommended for treating CAD because it is not effective in improving blood flow or relieving ischemia in coronary artery disease. Medications for post-MI discharge. Q4. How long should aspirin and P2Y12 inhibitors be continued after a myocardial infarction? A 4. Aspirin should be continued indefinitely, while P2Y12 inhibitors, such as clopidogrel, should be given for at least 12 months to prevent blood clots and further heart damage. Q5. When should a beta blocker be started after a myocardial infarction? A beta blocker should be started within 24 hours after a myocardial infarction. It helps reduce the risk of further heart issues and reduces mortality, especially if started before the patient is discharged. Q6. What is the role of statins in post-MI care? 6. Statins are given to all patients after an acute coronary syndrome, ACS, like MI, typically at a high intensity. The goal is to lower LDL cholesterol to below 70 milligrams per deciliter, which helps reduce the risk of further cardiovascular events. Q7. When are ACE inhibitors or ARBs indicated after an anterior myocardial infarction? 7. ACE inhibitors or ARBs are recommended for patients with an anterior wall MI, heart failure, or ejection fraction, EF, less than 40%, as they help prevent further heart damage and improve heart function. Q8. When should spironolactone be used after an MI? 8. Spironolactone is recommended for patients with an ejection fraction, EF, less than 40% after an MI to help reduce fluid retention and improve heart function. Q9. What are prophylactic antiarrhythmic medications, and what is the guideline for their use post-MI? 9. Prophylactic antiarrhythmic medications are used to prevent arrhythmias like ventricular tachycardia or fibrillation. However, amiodarone, flecainide, and other rhythm-controlling drugs should not be used post-MI, as they can increase mortality. Even if a patient has frequent PVCs, premature ventricular contractions, or ectopy, these medications should not be used. Sexual issues post-infarction. Q10. Why is it dangerous to combine nitrates with sildenafil after an MI? 10. Combining nitrates, which relax blood vessels, with sildenafil, Viagra, which also relaxes blood vessels, can cause severe hypotension, low blood pressure, which can be life-threatening. These drugs should not be taken together. Q11. What is the most common cause of erectile dysfunction, ED, post-infarction? 11. The most common cause of erectile dysfunction after an MI is anxiety, which can arise from concerns about health and recovery. However, beta blockers, a common medication used after an MI, are the most common drugs that can cause ED. Q12. How soon after a myocardial infarction can a patient resume sexual activity? 12. Patients should wait 2 to 4 weeks after an MI before resuming sexual activity, as long as they are symptom-free. The recovery time may be shorter for a small inferior MI than for an anterior wall MI, which typically requires a longer recovery period. Q13. What should be the next step if a post-MI patient's stress test is normal? 13. If the patient's stress test is normal, they can resume any form of exercise, including sexual activity, as tolerated. Summary of key points. Stress tests and angiography are used based on symptoms and reversible ischemia. Aspirin, P2Y12 inhibitors, beta blockers, statins, ACE inhibitors/ARBs, and spironolactone are key medications post-MI. Avoid antiarrhythmic medications like amiodarone post-MI due to increased mortality risk. Erectile dysfunction after an MI is most commonly due to anxiety, with beta blockers as the most common drug-related cause. Sexual activity can resume after 2 to 4 weeks post-MI if the patient is symptom-free and stress test results are normal. Congestive heart failure, CHF. Definition of CHF. Q1. What is congestive heart failure, CHF? 1. CHF is a condition where the heart is unable to pump blood effectively. This results in inadequate oxygen delivery to tissues and the buildup of fluid, especially in the lungs. The heart fails to work properly in pumping blood due to problems with its ability to contract or relax. Q2. What are the 2 types of dysfunction that lead to CHF? 2. The 2 types of dysfunction in CHF are systolic dysfunction. The heart has a low ejection fraction and is dilated, meaning it can't contract effectively to pump blood. Diastolic dysfunction. The heart can't relax properly and fill with blood, although the ejection fraction is often preserved or even higher than normal. Causes of systolic dysfunction. Q3. What is the most common cause of systolic dysfunction in CHF? A 3. The most common cause of systolic dysfunction is hypertension, which leads to heart muscle changes, called cardiomyopathy. Over time, this causes the heart to dilate and lose its pumping ability. Q4. How does hypertension lead to systolic dysfunction? A 4. Initially, hypertension causes the heart to work harder to pump blood, but over time, this leads to dilated cardiomyopathy, where the heart chambers stretch and weaken, reducing the ejection fraction, the amount of blood the heart pumps out with each beat. Q5. What role does myocardial infarction, MI, play in CHF? A 5. After an MI, heart attack, parts of the heart muscle become dead and no longer pump blood. This can lead to dilated cardiomyopathy and a decrease in ejection fraction, which contributes to CHF. Q6. What is the impact of heart valve disease on CHF? A 6. Valvular heart disease, diseased or malfunctioning heart valves, can lead to CHF by causing improper blood flow and increasing the heart's workload, leading to heart dilation and failure. Q7. What is the relationship between infarction, dilation, and regurgitation in CHF? A 7. The sequence is infarction, dilation, regurgitation, CHF. After an infarction, heart attack, the heart dilates, which can lead to regurgitation, improper valve closure, and ultimately leads to CHF. Q8. What are some less common causes of CHF? 8. Less common causes of CHF include alcohol use, post-viral myocarditis, radiation therapy, Chagas disease, hemochromatosis, which causes restrictive cardiomyopathy, thyroid disease, peripartum cardiomyopathy, thiamine deficiency, presentation of CHF. Q9. What is the main symptom of CHF? A 9. The main symptom of CHF is dyspnea, shortness of breath, especially on exertion, as the heart is unable to deliver enough oxygen to the body. Q10. What other symptoms may indicate CHF? A 10. Other symptoms of CHF include orthopnea, shortness of breath that worsens when lying flat and is relieved by sitting up, peripheral edema, swelling in the legs, feet, or abdomen due to fluid retention, rales, crackling sounds in the lungs, jugulovenous distension, JVD, swelling of the neck veins due to fluid buildup, paroxysmal nocturnal dyspnea, PND, sudden worsening of shortness of breath at night, usually during sleep. S3 gallop, an extra heart sound that indicates fluid overload and heart failure. Diagnosing CHF. Q11. How can you diagnose CHF without lab tests? 11. CHF can often be diagnosed through history and physical examination. The key signs are shortness of breath, dyspnea, lung rales, JVD, orthopnea, and PND. Q12. What is the most frequently asked question related to CHF in exams like USMLE Step 2 CK? A 12. The most common exam question is, what is the most likely diagnosis for a patient presenting with dyspnea? This question requires understanding the different causes of dyspnea to accurately diagnose CHF or other conditions. Differentiating dyspnea causes. Q13. What is the most likely diagnosis for sudden onset dyspnea with clear lungs? A 13. Pulmonary embolus is the most likely diagnosis for sudden onset dyspnea with clear lungs. Q14. What is the most likely diagnosis for sudden onset dyspnea with wheezing and an increased expiratory phase? A 14. Asthma is the most likely diagnosis when there is wheezing and prolonged exhalation. Q15. What is the most likely diagnosis for slow onset dyspnea with fever, sputum, and unilateral lung findings? Rale/Ronchi. A 15. Pneumonia is the most likely diagnosis for slow onset dyspnea with fever, sputum, and abnormal lung sounds on one side. Q16. What does dullness to percussion at the lung bases suggest? A 16. Pleural effusion, which is fluid buildup in the space around the lungs, is indicated by dullness to percussion at the bases of the lungs. Q17. What is the most likely diagnosis when there is tracheal deviation and decreased breath sounds unilaterally? A 17. Pneumothorax, collapsed lung, is likely if there is tracheal deviation and decreased breath sounds on one side of the chest. Q18. What is the most likely diagnosis with circumoral numbness, caffeine use, and a history of anxiety? 18. A panic attack is the most likely diagnosis with these symptoms. Q19. What is the most likely diagnosis for gradually worsening pallor over days to weeks? 19. Anemia is the most likely diagnosis for gradual pallor. Q20. What is the most likely diagnosis for pulsus paradoxus, decreased heart sounds, and jugulovenous distension? 20. Cardiac tamponade is the most likely diagnosis when these signs are present. Q21. What does the presence of palpitations and syncope indicate? 21. Arrhythmia, irregular heartbeat, of almost any kind is the most likely diagnosis for palpitations and syncope. Q22. What does a long smoking history and barrel chest suggest in a patient with dyspnea? 22. Chronic obstructive pulmonary disease, COPD, is most likely in this scenario. Q23. What is the most likely diagnosis for recent anesthetic use and cyanosis that doesn't improve with oxygen? 23. Methemoglobinemia, a condition where the blood is unable to carry oxygen properly, is most likely in this case. Q24. What is the most likely diagnosis for symptoms following exposure to carbon monoxide? 24. Carbon monoxide poisoning is the most likely diagnosis after exposure to carbon monoxide. Key features of CHF. Q25. What signs are not typically found in conditions that cause dyspnea but are found in CHF? 25. In conditions other than CHF, you will not find signs like orthopnea, paroxysmal nocturnal dyspnea, PND, or an S3 Gallup diagnostic test for CHF, congestive heart failure. General overview. Q1. What is the key to selecting the right test for CHF management? 1. The key to selecting the right test is understanding the setting, emergency department versus office or clinic, presence of acute symptoms like dyspnea, shortness of breath, and the type of CHF being considered chronic versus acute. Echocardiography in CHF. Q2. What is the most important test for diagnosing CHF? 2. Echocardiography is the most important test for diagnosing CHF. It helps assess heart function and the ejection fraction, the percentage of blood the heart pumps out with each beat. Q3. What is the best initial test to assess heart function in CHF? 3. The transthoracic echocardiogram, TT, is the best initial test to assess heart function and ejection fraction. Q4. What is the most accurate test for assessing ejection fraction? 4. The most accurate test is the multiple gated acquisition scan, MUGA, or nuclear ventriculography, which provides a detailed view of heart function. Q5. When should you consider nuclear ventriculography? 5. You should consider nuclear ventriculography when precision is required, such as for a patient receiving chemotherapy with doxorubicin, which may cause cardiomyopathy, and you need to monitor heart function carefully. Q6. What test is more accurate than TT in assessing heart valve function? 6. Transesophageal echocardiography, T, is more accurate than TT for evaluating heart valves and heart chamber sizes, but it is generally not needed for evaluating CHF specifically. BNP, B-type natriuretic peptide. Q7. When should you use BNP testing in CHF diagnosis? 7. BNP testing should be used when a patient presents with acute shortness of breath and the cause of the dyspnea is unclear. A normal BNP level can rule out CHF as the cause of the symptoms. Other tests for CHF. Q8. Are there any tests used to diagnose CHF directly? 8. No. The diagnosis of CHF is based on clinical signs and symptoms, history, and physical exam, with confirmation of the type of CHF using echocardiography. Q9. What tests help determine the underlying cause, etiology, of CHF? 9. Tests used to determine the cause of CHF include EKG, to identify myocardial infarction or heart block, chest X-ray, to diagnose dilated cardiomyopathy, Holter monitor, to detect paroxysmal arrhythmias, cardiac catheterization, to check valve function and septal defects, CBC, to check for anemia, Thyroid function tests to detect thyroid issues causing CHF. Endomyocardial biopsy to check for infiltrative diseases like sarcoidosis or amyloidosis. Swan-Ganz catheterization to distinguish CHF from ARDS. Q10. How is chest X-ray helpful in CHF? A chest X-ray can show signs of dilated cardiomyopathy, but it can miss cardiomegaly, enlarged heart, in up to half of cases. Treatment for systolic dysfunction, low ejection fraction. Q11. What are the main treatments for systolic dysfunction in CHF? 11. The main treatments for systolic dysfunction, low ejection fraction include ACE inhibitors or ARBs, beta blockers, spironolactone, diuretics, digoxin, ACE inhibitors, and ARBs. Q12. When should ACE inhibitors or ARBs be given to CHF patients? 12. ACE inhibitors, ACEs, or angiotensin receptor blockers, ARBs, should be given to all patients with systolic dysfunction, regardless of the stage of disease. Q13. What should be done if a patient experiences a cough from ACE inhibitors? 13. If a patient develops a cough from ACE inhibitors, they should be switched to an ARB, as ARBs do not cause this side effect. Q14. What is sacubitril with valsartan used for in CHF treatment? 14. Sacubitril with valsartan is an alternative to ACE inhibitors and lowers mortality in CHF patients. It is especially used in patients who experience a cough with ACE inhibitors. Q15. What is potiromer and when is it used? 15. Potiromer is an oral potassium binder used in patients with high potassium levels who need ACE inhibitors or ARBs to manage CHF but cannot use them due to elevated potassium. It helps reduce potassium levels while allowing the use of these medications. Beta blockers. Q16. Are beta blockers beneficial in all CHF patients with systolic dysfunction? 16. Beta blockers are effective in preventing sudden death from arrhythmias in chronic CHF, but should not be used during acute CHF episodes. Q17. Which beta blockers are effective for CHF? 17. The effective beta blockers for systolic dysfunction include metoprolol, bisoprolol, carvedilol. Q18. Why are beta blockers effective in treating CHF? 18. Beta blockers work by reducing the heart rate, which lowers oxygen demand and helps the heart pump more efficiently. Antiarrhythmic effects, preventing arrhythmias. Anti-ischemic effects, reducing the risk of heart attacks that could worsen CHF. Q19. Should beta blockers be used in acute CHF treatment? 19. No, beta blockers should not be used in the acute treatment of CHF, as they can worsen the patient's condition during an acute episode. Q20. What is the role of beta blockers in preventing sudden death in CHF patients? 20. Beta blockers prevent sudden death in CHF patients by reducing the likelihood of ventricular arrhythmias, which are common and can lead to fatal outcomes. Summary of diagnostic tests for CHF and treatment strategies. 1. Echocardiography is the most essential test for diagnosing CHF and assessing ejection fraction. 2. BNP testing helps rule out CHF in patients with unclear dyspnea. 3. Nuclear ventriculography is used for precise heart function assessment in high-risk chemotherapy patients. 4. ACE inhibitors, ARBs, beta blockers, and spironolactone are key treatments for systolic dysfunction in CHF. 5. Beta blockers are beneficial in long-term CHF management, but should not be used during acute episodes. Spironolactone and its role in CHF management. Spironolactone's mechanism of action. Q1. What is the main action of spironolactone in treating CHF? 1. Spironolactone works by inhibiting the effects of aldosterone, a hormone that contributes to fluid retention and worsening heart failure. By blocking aldosterone, spironolactone helps manage symptoms in advanced CHF. Indications for spironolactone use. Q2. In which stages of CHF is spironolactone proven effective? 2. Spironolactone is proven effective for advanced stages of CHF, specifically in class 3 and 4, where patients experience shortness of breath with minimal exertion or even at rest. Q3. Why is spironolactone only used in advanced CHF stages? 3. Spironolactone is most effective in advanced CHF stages where the heart is severely weakened and symptoms like shortness of breath are prominent. In earlier stages, its effects are less noticeable. Adverse effects of spironolactone. Q4. What are the common adverse effects of spironolactone? 4. The most common adverse effects of spironolactone are hyperkalemia, high potassium levels, and gynecomastia. Enlargement of male breast tissue. Q5. What should be done if a patient with CHF develops gynecomastia from spironolactone? 5. If a patient develops gynecomastia from spironolactone, the medication should be switched to eplerenone, which is an alternative that does not cause gynecomastia and still helps manage CHF. Eplerenone. Q6. What is eplerenone and how does it differ from spironolactone? 6. Eplerenone is an alternative to spironolactone that also inhibits aldosterone and lowers mortality in CHF. Unlike spironolactone, eplerenone does not cause antiandrogenic effects like gynecomastia. Q7. How does eplerenone benefit CHF patients? 7. Eplerenone helps reduce the symptoms of CHF and lowers mortality, making it a valuable treatment option for patients with severe heart failure. Q8. How are diuretics used in CHF treatment? 8. Diuretics like furosemide, torsemide, or bumetanide are used in the initial therapy of CHF with low ejection fraction. They help control symptoms by reducing fluid retention, but they do not lower mortality. Q9. What is the role of spironolactone as a diuretic? 9. Spironolactone acts as a diuretic, but it is used in higher doses where it doesn't provide a significant diuretic effect. Its primary role is to block aldosterone to manage advanced CHF. Digoxin. Q10. Does digoxin lower mortality in CHF? 10. No, digoxin does not lower mortality in CHF. It is used primarily to control symptoms of dyspnea, shortness of breath, and reduce hospitalizations. Q11. What is the role of digoxin in CHF treatment? 11. Digoxin is used in CHF to improve symptoms, particularly dyspnea, and to reduce the frequency of hospitalizations. However, it does not improve survival. Q12. Do other positive inotropic agents, like milrinone, dobutamine, lower mortality in CHF? 12. No, positive inotropic agents such as milrinone, amrinone, and dobutamine do not lower mortality in CHF. They are used to improve heart function temporarily, but do not provide long-term survival benefits. Hydralazine and nitrates. Q13. What is the role of hydralazine in CHF? 13. Hydralazine is a direct-acting arteriolar vasodilator that, when combined with nitrates, provides a survival advantage in systolic dysfunction. Q14. When are hydralazine and nitrates used in CHF treatment? 14. Hydralazine and nitrates are used when ACE inhibitors or ARBs cannot be used, as they help relieve symptoms and improve survival in patients with systolic dysfunction. Ivabradine. Q15. What is the role of ivabradine in treating systolic dysfunction in CHF? 15. Ivabradine is an SA nodal inhibitor that slows the heart rate by blocking funny channels. It is used when the heart rate is above 70 BPM and beta blockers cannot be used. Q16. What are the side effects of ivabradine? 16. Ivabradine can cause transient visual disturbances, such as seeing flashes of light. Sacubitril/valsartan. Q17. What is sacubitril/valsartan used for in CHF treatment? 17. Sacubitril/valsartan is a combination therapy used instead of an ACE inhibitor for systolic dysfunction. Sacubitril, a neprilysin inhibitor, provides mortality benefits in patients with heart failure. Q18. How does sacubitril/valsartan improve CHF outcomes? 18. Sacubitril inhibits neprilysin, which helps prevent the breakdown of beneficial peptides that improve heart function, while Valsartan is an ARB that helps relax blood vessels and reduce heart strain. Poor prognostic factors in heart failure. Q19. What clinical signs indicate a poor prognosis in heart failure? A 19. Poor prognosis is indicated by high NYHA class, hypotension, low blood pressure, tachycardia at rest, jugular venous distension (JVD), S3 heart sound, abnormal heart sound. Q20. What lab findings suggest a poor prognosis in heart failure? A 20. Poor prognosis is associated with hyponatremia, low sodium levels, elevated BNP, brain natriuretic peptide, renal insufficiency, kidney problems. Q21. What EKG abnormalities are linked to a poor prognosis in heart failure? A 21. Poor prognosis is suggested by QRS duration greater than 120 milliseconds, wide QRS complex, left bundle branch block, LBBB. Q22. What echocardiogram findings indicate a poor prognosis in heart failure? A 22. Poor prognosis is associated with severe reduction in ejection fraction, EF, pulmonary hypertension, diastolic dysfunction, right ventricular, RV, function impairment. Q23. What associated conditions worsen the prognosis of heart failure? A 23. Conditions like anemia, atrial fibrillation, and diabetes mellitus are linked to a worse prognosis in heart failure. Acute pulmonary edema. Definition. Q1. What is pulmonary edema? A 1. Pulmonary edema is a severe condition where fluid builds up quickly in the lungs, making it hard to breathe. It is the most serious form of congestive heart failure, CHF. Presentation symptoms. Q2. What are the common symptoms of pulmonary edema? A 2. Pulmonary edema presents suddenly with shortness of breath and the following signs. RALS, crackling sounds heard when breathing. JVD, jugular venous distension, bulging neck veins. S3 gallop, a specific heart sound heard with a stethoscope, often a sign of heart failure. Edema, swelling in the body, often in the legs. Orthopnea, difficulty breathing while lying down. Q3. Can pulmonary edema lead to other complications? A 3. Yes, if left untreated, pulmonary edema can lead to ascites, fluid buildup in the abdomen, an enlargement of the liver and spleen due to chronic congestion in the right side of the heart. Diagnostic tests. Q4. How is pulmonary edema diagnosed? A 4. There are several tests to help diagnose pulmonary edema. Brain natriuretic peptide, BNP, a blood test that helps determine if shortness of breath is due to pulmonary edema. A. Normal BNP level rules out pulmonary edema. Chest X-ray shows vascular congestion, swelling in blood vessels of the lungs, and cephalization of flow, which means blood flow is directed toward the upper part of the lungs, which is abnormal. Oximetry/arterial blood gases measures oxygen levels in the blood. In pulmonary edema, hypoxia, low oxygen levels is expected, and often respiratory alkalosis, low carbon dioxide levels, occurs due to hyperventilation. EKG, electrocardiogram important for identifying arrhythmias, abnormal heart rhythms that could cause or worsen pulmonary edema. Echocardiography, an ultrasound of the heart to check for systolic, pumping ability, or diastolic, filling ability, heart dysfunction. However, it is not urgent in the acute setting of pulmonary edema. Treatment and management. Q5. What is the best initial therapy for acute pulmonary edema? A 5. The best initial therapy is to remove excess fluid from the body using a loop diuretic. This helps to reduce the fluid in the lungs and improve breathing. Q6. What should be done for oxygen therapy in pulmonary edema? A 6. Oximetry, measuring oxygen levels, should be done, but it does not change the acute treatment. Oxygen should be given because the patient has shortness of breath and is hyperventilating. Q7. What role does echocardiography play in treating pulmonary edema? A 7. Echocardiography should be done to check if there is systolic or diastolic dysfunction, heart problems, but it is not needed immediately for treatment. It can help guide future care. Q8. When should cardioversion be used in pulmonary edema? 8. If pulmonary edema is caused by an arrhythmia, abnormal heart rhythm, like atrial fibrillation, atrial flutter, or ventricular tachycardia, the first treatment is rapid synchronized cardioversion to restore the normal heart rhythm. This helps improve heart function and reduce pulmonary edema. Q9. When is ramipril or an ACE inhibitor, ACEI, used in pulmonary edema? A 9. Ramipril, an ACE inhibitor, should be used if the patient has systolic dysfunction, weak heart pumping, but it is not the first thing to do in an acutely unstable patient with pulmonary edema. Q10. Is there a role for beta blockers in acute pulmonary edema? A 10. Beta blockers, like metoprolol, are used in some heart failure patients but should not be the first treatment in an acute pulmonary edema episode. The priority is to remove fluid and provide oxygen. Q11. What is naziretide and does it help in pulmonary edema? 11. Naziretide is a medication given intravenously that works like nitrates, helping to reduce fluid in the body. However, it does not reduce mortality and is not as effective as other treatments for acute pulmonary edema. Summary of key points. 1. Pulmonary edema is a severe form of CHF where fluid builds up rapidly in the lungs, causing shortness of breath and other symptoms like rales, JVD, and edema. 2. Diagnostic tests include BNP, chest X-ray, oxygen measurement, EKG, and echocardiography. 3. The best initial therapy for acute pulmonary edema is to use a loop diuretic to remove fluid, along with oxygen therapy. 4. If the cause is an arrhythmia, cardioversion is needed to restore normal heart rhythm. 5. Echocardiography is helpful for diagnosing heart dysfunction, but not urgent in an acute setting. 6. Naziretide and ACE inhibitors may be used, but they do not provide immediate benefits in acute pulmonary edema. Compared to fluid removal and oxygen therapy, treatment of acute pulmonary edema and valvular heart disease. Preload reduction. Q1. What is the initial therapy for acute pulmonary edema? 1. The initial therapy for acute pulmonary edema includes the following. Oxygen, to improve oxygen levels in the blood. Loop diuretics, like furosemide or bumetanide, these medications remove excess fluid from the body and lungs. Nitrates, help to relax blood vessels and reduce heart workload. Morphine, can relieve pain and reduce anxiety, helping to ease breathing. Q2. Why are loop diuretics like furosemide helpful in acute pulmonary edema? 2. Loop diuretics like furosemide are helpful because they remove fluid from the body, which reduces the fluid buildup in the lungs and improves breathing. Q3. How do nitrates help in pulmonary edema treatment? 3. Nitrates help by relaxing blood vessels, reducing the preload, the amount of blood returning to the heart, and decreasing the strain on the heart. However, they can be dangerous if the patient has a recent heart attack or aortic stenosis. Q4. What is the role of morphine in pulmonary edema treatment? 4. Morphine helps by reducing pain and anxiety, which can make it easier for the patient to breathe. Q5. Is naziretide more effective than diuretics and nitrates in acute pulmonary edema? 5. No, naziretide, a type of atrial natriuretic peptide, is not more effective than diuretics and nitrates for acute pulmonary edema. Diuretics and nitrates are the preferred treatment positive inotropic agents. Q6. What are positive inotropic agents and when are they used? 6. Positive inotropic agents increase the contractility, pumping power of the heart. They are used when patients don't respond well to fluid removal, diuretics, and need additional support. Examples include dobutamine, used in the ICU when the patient's symptoms are not improving with preload reduction. Amrinone and milrinone. These drugs also increase heart contractility and reduce afterload resistance against heart pumping. Q7. Can digoxin be used as a positive inotropic agent in acute pulmonary edema? 7. Digoxin can increase contractility, but it takes weeks to show an effect, so it is not useful in the acute setting of pulmonary edema. Summary. 1. Spironolactone and eplerenone block aldosterone to manage symptoms and reduce mortality in advanced CHF. 2. Diuretics help control CHF symptoms, but they do not lower mortality. 3. Digoxin improves symptoms, but does not reduce CHF mortality. 4. Hydralazine and nitrates provide a survival advantage when ACE inhibitors or ARBs cannot be used. 5. Ivabradine is used to lower heart rate in systolic dysfunction if beta blockers can't be used. 6. Sacubitril/valsartan offers significant mortality benefits in systolic dysfunction. 7. Poor prognosis in CHF is linked to specific clinical, lab, EKG, and echocardiogram findings. Devices for CHF treatment. Implantable defibrillator. Q1. What is an implantable defibrillator and how does it help in CHF treatment? 1. An implantable defibrillator is a device placed under the skin that can shock the heart back into a normal rhythm if it detects a dangerous arrhythmia. It is especially helpful for people with ischemic cardiomyopathy, heart disease due to poor blood flow, and an ejection fraction, how much blood the heart pumps out with each beat, below 35%. Q2. How much does an implantable defibrillator reduce the risk of death in CHF patients? 2. The implantable defibrillator can reduce the risk of death by as much as 25% in patients with ischemic cardiomyopathy and low ejection fraction. Q3. Why is an implantable defibrillator important in CHF? 3. Arrhythmia, irregular heartbeat, and sudden death are the most common causes of death in CHF. The defibrillator helps prevent sudden death by correcting dangerous heart rhythms. Q4. What is a life vest in CHF treatment? 4. A life vest is a temporary, externally wearable defibrillator. It is worn by patients who are at risk for dangerous arrhythmias while waiting for an implantable defibrillator. Biventricular pacemaker. Q5. What is a biventricular pacemaker and when is it used in CHF treatment? 5. A biventricular pacemaker is a device used to treat CHF in patients with dilated cardiomyopathy, weakened heart muscle, and ejection fraction under 35%, especially when the QRS duration, the time for electrical signals to travel through the heart, is greater than 140 milliseconds and symptoms persist. Q6. How does a biventricular pacemaker help CHF patients? 6. The biventricular pacemaker helps resynchronize the heart by improving the coordination of the heart's contractions, especially when there is a conduction defect, a problem with how the heart's electrical signals travel. This helps improve heart function and symptoms. Q7. What is the difference between a biventricular pacemaker and a dual-chamber pacemaker? 7. A dual-chamber pacemaker has wires in both an atrium and a ventricle and helps regulate the timing between the chambers. In contrast, a biventricular pacemaker has wires in both ventricles and helps coordinate the contractions of both sides of the heart, which is important for patients with conduction problems. Q8. How does a biventricular pacemaker improve CHF outcomes? 8. Many patients who might otherwise need a heart transplant have experienced significant improvement in symptoms with a biventricular pacemaker, allowing them to function better and avoid transplant. Cardiac transplantation. Q9. When is cardiac transplantation considered in CHF treatment? 9. Cardiac transplantation is considered when maximal medical therapy, including ACE inhibitors, beta blockers, spironolactone, diuretics, digoxin, and possibly a biventricular pacemaker, fails to control CHF symptoms. This is the last option for severe CHF patients. Medications in systolic dysfunction, CHF with low ejection fraction. Medications that lower mortality in systolic dysfunction. Q10. What medications provide a mortality benefit in systolic dysfunction? Low ejection fraction, CHF. 10. The medications that provide a mortality benefit include ACE inhibitors, ACEs, or angiotensin II receptor blockers, ARBs, beta blockers, spironolactone or eplerenone, hydralazine/nitrates, implantable defibrillator, sacubitril. Q11. How does patiramer help in CHF treatment? 11. Patiramer is used to lower potassium levels, allowing for the use of medications like ACE inhibitors, ARBs, and Spironolactone, which can raise potassium levels and cause problems in high amounts. Treatment of diastolic dysfunction, CHF with preserved ejection fraction. Management of diastolic dysfunction. Q12. What is diastolic dysfunction and how is it different from systolic dysfunction in CHF? A 12. Diastolic dysfunction occurs when the heart's muscle becomes stiff and has trouble filling with blood, even though it may still pump blood normally. In contrast, systolic dysfunction occurs when the heart's pumping ability is weakened, leading to reduced ejection fraction. Q13. What medications are useful for diastolic dysfunction? CHF with preserved ejection fraction? A 13. The medications clearly beneficial for diastolic dysfunction include spironolactone, helps reduce fluid overload. Diuretics, to control symptoms of fluid overload. Q14. Which medications are not beneficial for diastolic dysfunction? A 14. Beta blockers and digoxin are not beneficial for diastolic dysfunction and should not be used. Q15. Are ACE inhibitors and ARBs helpful in diastolic dysfunction? A 15. The benefit of ACE inhibitors and ARBs in diastolic dysfunction is unclear. They may help in some patients, but their role is not well defined. Q16. When should beta blockers be used in diastolic dysfunction? A 16. Beta blockers should only be used in diastolic dysfunction if the patient also has another condition, such as coronary artery disease, CAD, that requires their use. Treatment of hypertrophic obstructive cardiomyopathy, HOCM. Q17. How is hypertrophic obstructive cardiomyopathy, HOCM, different from diastolic dysfunction? A 17. HOCM is a congenital condition where the septum, wall between the heart's two ventricles, becomes asymmetrically enlarged, obstructing the flow of blood from the left ventricle. Q18. Why are diuretics contraindicated in HOCM? 18. Diuretics are contraindicated in HOCM because they can increase the obstruction in the left ventricular outflow tract, making the condition worse. Summary of key points. 1. Implantable defibrillators help prevent sudden death in patients with ischemic cardiomyopathy and low ejection fraction. 2. Biventricular pacemakers help resynchronize the heart and improve symptoms in patients with dilated cardiomyopathy and conduction defects. 3. Cardiac transplantation is the last resort when other treatments fail in severe CHF cases. 4. In systolic dysfunction, medications like ACEs, beta blockers, and spironolactone can lower mortality. 5. In diastolic dysfunction, spironolactone and diuretics are helpful, while digoxin and beta blockers are not beneficial. 6. HOCM is a congenital condition with a risk of obstruction. Diuretics should be avoided in these patients. Afterload reduction. Q8. How can afterload, resistance against heart pumping, be reduced in acute pulmonary edema? 8. In the acute setting, nitroprusside, an intravenous drug, and hydralazine, a vasodilator, can be used to reduce afterload and make it easier for the heart to pump blood. Q9. What role do ACE inhibitors, ACEs, and ARBs play in treating pulmonary edema? 9. ACE inhibitors, ACEs, and ARBs are used for long-term treatment in patients with systolic dysfunction and low ejection fraction. They help reduce afterload and improve heart function, but they are not the first treatment in an acute pulmonary edema episode. Q10. Is heparin useful for acute pulmonary edema? A 10. Heparin is not helpful for acute pulmonary edema unless there is a clot. It is not part of the routine management for pulmonary edema. Valvular heart disease. Definition and presentation. Q11. What are the causes of valvular heart disease? 11. Valvular heart disease can be congenital, present at birth, caused by rheumatic fever, often leading to mitral stenosis, associated with aging, leading to aortic stenosis, caused by hypertension or ischemic heart disease, leading to regurgitation. Q12. What are the symptoms of valvular heart disease? 12. The main symptoms of valvular heart disease are shortness of breath and the common signs of congestive heart failure, CHF. However, heart murmurs are the most specific way to diagnose it. Q13. How can you tell the difference between right-sided and left-sided valvular lesions based on breath? 13. Right-sided lesions, like tricuspid or pulmonic valve, become louder with inhalation because inhaling increases blood flow to the right side of the heart. Left-sided lesions, like mitral or aortic valve, become louder with exhalation because exhalation pushes blood from the lungs into the left side of the heart. Diagnostic tests. Q14. What is the best initial test for diagnosing valvular heart disease? 14. The best initial test is an echocardiogram, which uses sound waves to produce images of the heart. A transesophageal echocardiogram, done through the esophagus, is often more sensitive and specific than a transthoracic echo, done on the chest. Q15. What is the most accurate test for valvular heart disease? 15. Cardiac catheterization is the most accurate test. It involves inserting a catheter into the heart to measure pressures and the exact size of the valve opening. Q16. What role does EKG play in diagnosing valvular heart disease? 16. The EKG can show signs of chamber hypertrophy, enlargement, but it cannot confirm valvular heart disease on its own. Q17. Is chest X-ray useful for diagnosing valvular heart disease? 17. Chest X-ray may show signs of chamber enlargement, heart size changes, but it's not very specific and should not be relied on to diagnose valvular heart disease. Treatment. Q18. How is fluid overload managed in valvular heart disease? 18. Since fluid overload is common in valvular heart disease, diuretics are often used to help remove excess fluid from the lungs and the body. Q19. What is the treatment for mitral stenosis and aortic stenosis? 19. For mitral stenosis, a balloon dilation can be used to open the valve. For aortic stenosis, the valve may need to be surgically removed or replaced. Q20. How are regurgitant lesions treated? 20. Regurgitant lesions, where the valve does not close properly, respond well to vasodilators like ACE inhibitors, ARBs, nifedipine, and hydralazine. If the heart becomes too dilated, valve replacement surgery is needed. Q21. When should valve replacement surgery be done? 21. Valve replacement surgery should be done before the heart becomes too dilated. If the heart stretches too much, the valve replacement may not fix the heart's pumping function. Q22. What is the role of endocarditis prophylaxis in valvular heart disease? 22. Endocarditis prophylaxis, preventive treatment for heart infections, is only necessary if a valve has been replaced or the patient has had previous endocarditis. It is not needed for all types of valvular heart disease. Summary of key points. 1. Pulmonary edema is treated with oxygen, diuretics, nitrates, and morphine to reduce fluid buildup and ease breathing. 2. If symptoms don't improve, positive inotropic agents like dobutamine may be used. 3. ACE inhibitors and ARBs can be used for long-term management of heart failure, while nitroprusside and hydralazine help with afterload reduction in acute settings. 4. Valvular heart disease can be caused by conditions like rheumatic fever or aging and is treated with medications and, in some cases, surgery, e.g., valve replacement or dilation. Diuretics are used to manage fluid overload in the lungs. 5. Echocardiography is the best initial test for diagnosing valvular heart disease, while cardiac catheterization is the most accurate test. Mitral stenosis, MS. Definition and etiology. Q1. What is mitral stenosis, MS? 1. Mitral stenosis, MS, is a condition where the mitral valve in the heart becomes narrowed, making it harder for blood to flow from the left atrium to the left ventricle. Q2. What is the most common cause of mitral stenosis? 2. The most common cause of mitral stenosis is rheumatic fever, an infection caused by untreated strep throat that affects the heart valves. Q3. Why is mitral stenosis rare in the United States? 3. Mitral stenosis is rare in the United States because acute rheumatic fever, the leading cause, is uncommon due to better treatment of strep throat infections. Q4. What is the critical narrowing of the mitral valve in mitral stenosis? A 4. Critical narrowing of the mitral valve is when the valve opening is smaller than 1 square centimeter, which makes it very hard for blood to pass through. Q5. When should mitral stenosis be treated? A 5. Mitral stenosis is treated when it causes symptoms. If the condition does not cause symptoms, treatment is usually not necessary. Q6. What should be considered in the patient's history when diagnosing mitral stenosis? A 6. Pregnancy and immigration history should be considered. Pregnancy increases blood volume and can stress a narrow valve, and immigrants from regions where rheumatic fever is common are at higher risk. Presentation. Q7. What are the common symptoms of mitral stenosis? A 7. Mitral stenosis causes shortness of breath and congestive heart failure, CHF, which are typical of all types of valvular heart disease. Q8. What are some unique symptoms of mitral stenosis? A 8. Unique symptoms include dysphagia, difficulty swallowing due to the left atrium pressing on the esophagus, hoarseness due to the left atrium pressing on the laryngeal nerve, atrial fibrillation, and stroke due to the enlargement of the left atrium, hemoptysis, coughing up blood due to pressure on the lungs. Physical findings. Q9. What kind of murmur is heard in mitral stenosis? A 9. The murmur is diastolic, heard when the heart is relaxed, and occurs just after an opening snap, a sound made when the mitral valve opens. Q10. How do squatting and leg raising affect the murmur in mitral stenosis? A 10. Squatting and leg raising increase the intensity of the murmur because they increase venous return. More blood flows to the heart, which worsens the narrowing of the mitral valve. Afterload reduction. Q8. How can afterload, resistance against heart pumping, be reduced in acute pulmonary edema? A 8. In the acute setting, nitroprusside, an intravenous drug, and hydralazine, a vasodilator, can be used to reduce afterload and make it easier for the heart to pump blood. Q9. What role do ACE inhibitors, ASAs, and ARBs play in treating pulmonary edema? A 9. ACE inhibitors, ASAs, and ARBs are used for long-term treatment in patients with systolic dysfunction and low ejection fraction. They help reduce afterload and improve heart function, but they are not the first treatment in an acute pulmonary edema episode. Q10. Is heparin useful for acute pulmonary edema? A 10. Heparin is not helpful for acute pulmonary edema unless there is a clot. It is not part of the routine management for pulmonary edema. Valvular heart disease. Definition and presentation. Q11. What are the causes of valvular heart disease? 11. Valvular heart disease can be congenital, present at birth, caused by rheumatic fever, often leading to mitral stenosis, associated with aging, leading to aortic stenosis, caused by hypertension or ischemic heart disease, leading to regurgitation. Q12. What are the symptoms of valvular heart disease? A 12. The main symptoms of valvular heart disease are shortness of breath and the common signs of congestive heart failure, CHF. However, heart murmurs are the most specific way to diagnose it. Q13. How can you tell the difference between right-sided and left-sided valvular lesions based on breath? A 13. Right-sided lesions, like tricuspid or pulmonic valve, become louder with inhalation because inhaling increases blood flow to the right side of the heart. Left-sided lesions, like mitral or aortic valve, become louder with exhalation because exhalation pushes blood from the lungs into the left side of the heart. Diagnostic test. Q14. What is the best initial test for diagnosing valvular heart disease? A 14. The best initial test is an echocardiogram, which uses sound waves to produce images of the heart. A transesophageal echocardiogram, done through the esophagus, is often more sensitive and specific than a transthoracic echo, done on the chest. Q15. What is the most accurate test for valvular heart disease? A 15. Cardiac catheterization is the most accurate test. It involves inserting a catheter into the heart to measure pressures and the exact size of the valve opening. Q16. What role does EKG play in diagnosing valvular heart disease? A 16. The EKG can show signs of chamber hypertrophy, enlargement, but it cannot confirm valvular heart disease on its own. Q17. Is chest X-ray useful for diagnosing valvular heart disease? A 17. Chest X-ray may show signs of chamber enlargement, heart size changes, but it's not very specific and should not be relied on to diagnose valvular heart disease. Treatment. Q18. How is fluid overload managed in valvular heart disease? 18. Since fluid overload is common in valvular heart disease, diuretics are often used to help remove excess fluid from the lungs and the body. Q19. What is the treatment for mitral stenosis and aortic stenosis? A 19. For mitral stenosis, a balloon dilation can be used to open the valve. For aortic stenosis, the valve may need to be surgically removed or replaced. Q20. How are regurgitant lesions treated? A 20. Regurgitant lesions, where the valve does not close properly, respond well to vasodilators like ACE inhibitors, ARBs, nifedipine, and hydralazine. If the heart becomes too dilated, valve replacement surgery is needed. Q21. When should valve replacement surgery be done? A 21. Valve replacement surgery should be done before the heart becomes too dilated. If the heart stretches too much, the valve replacement may not fix the heart's pumping function. Q22. What is the role of endocarditis prophylaxis in valvular heart disease? A 22. Endocarditis prophylaxis, preventive treatment for heart infections, is only necessary if a valve has been replaced or the patient has had previous endocarditis. It is not needed for all types of valvular heart disease. Summary of key points. 1. Pulmonary edema is treated with oxygen, diuretics, nitrates, and morphine to reduce fluid buildup and ease breathing. 2. If symptoms don't improve, positive inotropic agents like dobutamine may be used. 3. ACE inhibitors and ARBs can be used for long-term management of heart failure, while nitroprusside and hydralazine help with afterload reduction in acute settings. 4. Valvular heart disease can be caused by conditions like rheumatic fever or aging and is treated with medications and, in some cases, surgery, e.g., valve replacement or dilation. Diuretics are used to manage fluid overload in the lungs. 5. Echocardiography is the best initial test for diagnosing valvular heart disease, while cardiac catheterization is the most accurate test. Mitral stenosis, MS. Definition and etiology. Q1. What is mitral stenosis, MS? A 1. Mitral stenosis, MS, is a condition where the mitral valve in the heart becomes narrowed, making it harder for blood to flow from the left atrium to the left ventricle. Q2. What is the most common cause of mitral stenosis? A 2. The most common cause of mitral stenosis is rheumatic fever, an infection caused by untreated strep throat that affects the heart valves. Q3. Why is mitral stenosis rare in the United States? A 3. Mitral stenosis is rare in the United States because acute rheumatic fever, the leading cause, is uncommon due to better treatment of strep throat infections. Q4. What is the critical narrowing of the mitral valve in mitral stenosis? A 4. Critical narrowing of the mitral valve is when the valve opening is smaller than 1 square centimeter, which makes it very hard for blood to pass through. Q5. When should mitral stenosis be treated? A 5. Mitral stenosis is treated when it causes symptoms. If the condition does not cause symptoms, treatment is usually not necessary. Q6. What should be considered in the patient's history when diagnosing mitral stenosis? A 6. Pregnancy and immigration history should be considered. Pregnancy increases blood volume and can stress a narrow valve, and immigrants from regions where rheumatic fever is common are at higher risk. Presentation. Q7. What are the common symptoms of mitral stenosis? A 7. Mitral stenosis causes shortness of breath and congestive heart failure, CHF, which are typical of all types of valvular heart disease. Q8. What are some unique symptoms of mitral stenosis? A 8. Unique symptoms include dysphagia, difficulty swallowing, due to the left atrium pressing on the esophagus, Hoarseness due to the left atrium pressing on the laryngeal nerve. Atrial fibrillation and stroke due to the enlargement of the left atrium. Hemoptysis, coughing up blood due to pressure on the lungs. Physical findings. Q9. What kind of murmur is heard in mitral stenosis? A 9. The murmur is diastolic, heard when the heart is relaxed, and occurs just after an opening snap, a sound made when the mitral valve opens. Q10. How do squatting and leg raising affect the murmur in mitral stenosis? A 10. Squatting and leg raising increase the intensity of the murmur because they increase venous return. More blood flows to the heart, which worsens the narrowing of the mitral valve. Diagnostic tests. Q11. What is the best initial test for diagnosing mitral stenosis? O11. The best initial test is a transthoracic echocardiogram, TT, which uses sound waves to create images of the heart. Transesophageal echocardiogram, T, is more accurate than TT, but is used less frequently. Q12. What is the most accurate test for diagnosing mitral stenosis? A 12. Cardiac catheterization is the most accurate test because it directly measures the size of the valve opening and the pressure in the heart. Q13. What does an EKG show in patients with mitral stenosis? A 13. An EKG often shows atrial fibrillation, irregular heartbeat. It also shows left atrial hypertrophy, which appears as a biphasic P wave in leads V1 and V2, indicating an enlarged left atrium. Q14. What findings on a chest X-ray are typical for mitral stenosis? A 14. On a chest X-ray, signs of left atrial hypertrophy include straining of the left heart border, elevation of the left mainstem bronchus, a second bubble behind the heart caused by an enlarged left atrium. Treatment. Q15. How is fluid overload managed in mitral stenosis? A 15. Fluid overload in the lungs is managed with diuretics, medications that help remove excess fluid, and sodium restriction, limiting salt intake. Q16. What is the treatment for severe mitral stenosis that cannot be treated with medication? A 16. If medication doesn't help, balloon valvuloplasty is a procedure where a balloon is inserted into the valve and inflated to open it up. Q17. When is valve replacement necessary in mitral stenosis? A 17. Valve replacement is done when balloon valvuloplasty is not possible or it fails to improve the condition. Q18. How is atrial fibrillation treated in patients with mitral stenosis? A 18. Patients with atrial fibrillation due to mitral stenosis are treated with warfarin to prevent blood clots, aiming for an INR, international normalized ratio, of 2 to 3. If the patient has non-valvular atrial fibrillation, no mitral valve issue. Other blood thinners called NOACs, non-vitamin K, oral anticoagulants, are used instead. Q19. How is rate control of atrial fibrillation managed? A 19. Rate control for atrial fibrillation can be achieved with medications such as digoxin, beta blockers, diltiazem or verapamil, calcium channel blockers. Summary of key points. 1. Mitral stenosis, MS, is commonly caused by rheumatic fever, which leads to narrowing of the mitral valve. It is rare in the U.S., but more common in immigrants from regions where rheumatic fever is still prevalent. 2. Symptoms of mitral stenosis include shortness of breath, swallowing difficulties, dysphagia, hoarseness, and complications like atrial fibrillation and stroke. 3. The best initial diagnostic test is transthoracic echocardiography, TT, and the most accurate test is cardiac catheterization. 4. Treatment includes the use of diuretics, balloon valvuloplasty, and, if needed, valve replacement. Atrial fibrillation is managed with warfarin or NOACs and rate control medications like digoxin or beta blockers. Aortic stenosis, AS. Definition and etiology. Q1. What is aortic stenosis, AS? A1. Aortic stenosis, AS, is a condition where the aortic valve, which controls blood flow from the left ventricle to the aorta, becomes narrowed, making it harder for blood to flow through. Q2. What causes aortic stenosis? A 2. Aortic stenosis can be caused by a congenital bicuspid valve, a valve with only 2 leaflets instead of 3, or by calcification, calcium buildup, as people age. Presentation. Q3. What are the common symptoms of aortic stenosis? 3. The most common symptoms of aortic stenosis include angina, chest pain, syncope, fainting, congestive heart failure (CHF), which has the poorest prognosis with an average survival of only 2 years. Murmur. Q4. What type of murmur is heard in aortic stenosis? 4. The murmur is a systolic crescendo-decrescendo, increasing and then decreasing in intensity murmur. It peaks in mid-systole, making a diamond shape during the heart's contraction. Q5. Where is the aortic stenosis murmur heard best? 5. The murmur is heard best at the second right intercostal space, just below the second rib on the right side of the chest, and can radiate to the carotid artery, the major blood vessel in the neck. Q6. How do certain maneuvers affect the aortic stenosis murmur? 6. The Valsalva maneuver, a forced exhalation against a closed mouth, and standing can decrease the intensity of the murmur, because they reduce blood flow to the heart, decreased venous return. In contrast, hand grip, squeezing your hands together tightly, softens the murmur because it decreases the heart's ability to pump blood effectively. Diagnostic tests. Q7. What tests are used to diagnose aortic stenosis? 7. The tests used in diagnosing aortic stenosis include transthoracic echocardiogram, TT. This is the best initial test, which uses sound waves to create an image of the heart. Transesophageal echocardiogram, T. This test is more accurate than TT, but requires a tube to be placed in the patient's esophagus to get better pictures of the heart. Cardiac catheterization. This is the most accurate test and involves inserting a thin tube into the heart to measure pressures and check for blockages. Q8. What does an EKG show in patients with aortic stenosis? 8. The EKG often shows left ventricular hypertrophy (LVH), which is thickening of the left ventricle. This appears as a S wave in lead V1 and an R wave in lead V5, with a total amplitude greater than 35 millimeters. Treatment. Q9. What is the only truly effective treatment for aortic stenosis? 9. The only truly effective treatment for aortic stenosis is valve replacement, either through surgery or other procedures. Q10. Can diuretics be used in the treatment of aortic stenosis? 10. Diuretics, medications that remove excess fluid, can be used to treat congestive heart failure, CHF, caused by aortic stenosis, but they are not very effective because patients with aortic stenosis do not tolerate volume depletion, removing too much fluid from the body. Q11. Is balloon valvuloplasty commonly used for aortic stenosis? 11. Balloon valvuloplasty, a procedure where a balloon is inflated in the valve to widen it, is not routinely done for aortic stenosis because the calcification in the valve doesn't improve much with this procedure. However, it may be used in patients who are too unstable for surgery. Q12. What is transcatheter aortic valve replacement, TAVR? 12. TAVR is a procedure where a new aortic valve is inserted into the heart using a catheter, without needing open-heart surgery. It is an alternative to surgical valve replacement and is sometimes used in high-risk patients. Q13. How does TAVR differ from balloon valvuloplasty? 13. TAVR is a valve replacement, whereas balloon valvuloplasty just widens the valve opening without replacing the valve. TAVR is more effective than balloon dilation for aortic stenosis. Q14. What are the advantages and risks of TAVR compared to surgery? 14. TAVR has a slightly lower risk of death compared to surgery, but it may have a higher risk of complications such as residual aortic regurgitation (AR), blood leaking back into the heart, and the need for a pacemaker to regulate heart rhythm. Surgery has a higher risk of acute kidney injury, AKI, and atrial fibrillation, a condition where the heart beats irregularly. Summary of key points. 1. Aortic stenosis, AS, occurs when the aortic valve narrows, often due to bicuspid valve, present from birth or calcification. With aging. 2. Common symptoms of AS include angina, chest pain, syncope, fainting, and congestive heart failure (CHF). 3. The characteristic murmur in AS is systolic, with a crescendo-decrescendo pattern, and is heard best at the second right intercostal space, radiating to the carotid arteries. The main treatment for aortic stenosis is valve replacement, either through surgery or transcatheter aortic valve replacement (TAVR). 5. Diuretics can help manage CHF, but balloon valvuloplasty is not commonly used due to the calcification in the valve. 6. TAVR is an alternative to surgery, particularly for high-risk patients, and involves valve replacement through a catheter. Rather than surgery, mitral regurgitation, MR. Definition and etiology. Q1. What is mitral regurgitation? 1. Mitral regurgitation, MR, is when blood flows backward through the mitral valve, which is supposed to prevent this because the valve does not close properly. This can happen due to hypertension, endocarditis, infection of the heart lining, a heart attack that causes damage to the valve, or any condition that causes the heart to dilate stretch. Q2. What causes mitral regurgitation? 2. Mitral regurgitation can be caused by hypertension, high blood pressure, endocarditis, infection of the heart, myocardial infarction, heart attack, with rupture of the papillary muscles in the heart that help control the valve. Any condition that causes the heart to dilate stretch can also lead to MR. Presentation. Q3. What are the symptoms of mitral regurgitation? 3. Mitral regurgitation presents with the same symptoms as congestive heart failure, CHF, which includes shortness of breath, fluid buildup, and fatigue. The unique finding is a murmur. Q4. What is the murmur like in mitral regurgitation? 4. The murmur in mitral regurgitation is pansystolic, holosystolic, meaning it lasts throughout the entire contraction of the heart, obscuring both S1 and S2, the normal heart sounds. This murmur is heard best over the axilla, armpit area. Q5. How do certain maneuvers affect the murmur of mitral regurgitation? 5. Certain maneuvers can affect the murmur of mitral regurgitation. Hand grip, squeezing your hands together tightly, will worsen the murmur by increasing the amount of blood flowing backward through the valve. Hand grip increases afterload resistance the heart works against, making the regurgitation worse. Squatting and leg raising also worsen the murmur by increasing the venous return, more blood returning to the heart. All left-sided heart murmurs, except for mitral valve prolapse, MVP, and hypertrophic obstructive cardiomyopathy, HOCM, will increase with expiration, breathing out. Diagnostic tests. Q6. How is mitral regurgitation diagnosed? 6. Mitral regurgitation is diagnosed with echocardiography, which is an ultrasound of the heart that helps visualize the blood. Low and valve function. Treatment. Q7. What is the treatment for mitral regurgitation? 7. The treatment for mitral regurgitation includes vasodilators like ACE inhibitors, ASAs, or angiotensin receptor blockers, ARBs, which help relax the blood vessels and reduce the heart's workload. However, no drug can slow down the progression of the disease. Digoxin and diuretics, water pills, can be used to treat symptoms of CHF in Mr. patients. Valve replacement is indicated when the heart starts to dilate. Do not wait for the left ventricular end systolic diameter, LVEST, to become too large because the damage becomes irreversible. Valve repair or replacement is done when LVEST is above 40 millimeters or when the heart's ejection fraction, EF, drops below 60%. Q8. How is mitral valve replacement performed? 8. Mitral valve replacement can be done through surgery or by using a catheter to place a clip or sutures across the valve to tighten it and reduce regurgitation. This is known as valve repair aortic regurgitation, AR. Definition and etiology. Q9. What is aortic regurgitation? 9. Aortic regurgitation, AR, is when blood leaks backward into the left ventricle from the aorta because the aortic valve does not close properly. This can be caused by myocardial infarction, heart attack, hypertension, high blood pressure, endocarditis, heart infection, Marfan syndrome or cystic medial necrosis, genetic and connective tissue disorders, inflammatory disorders like ankylosing spondylitis or Reiter syndrome, syphilis and infection. Presentation. Q10. What are the symptoms of aortic regurgitation? A 10. In addition to symptoms of congestive heart failure, CHF, aortic regurgitation has some unique physical signs, including wide pulse pressure. The difference between systolic and diastolic blood pressure is unusually large. Water hammer pulse, a large, bounding pulse. Quink pulse, pulsations in the nail bed. Hill sign, blood pressure in the legs up to 40 millimeters of mercury higher than in the arms. Head bobbing, a rhythmic head movement called de Musset sign. Murmur. Q11. What does the murmur of aortic regurgitation sound like? 11. The murmur of aortic regurgitation is a diastolic decrescendo murmur, meaning it starts loud and gets softer as the heart relaxes. It is best heard at the lower left sternal border. Q12. How do certain maneuvers affect the murmur of aortic regurgitation? A 12. Certain maneuvers can affect the murmur of aortic regurgitation. Valsalva maneuver, forced exhalation, and standing make the murmur better by reducing venous return to the heart. Hand grip, squeezing the hands tightly, worsens the murmur by increasing afterload, the resistance the heart has to pump. Against. Diagnostic tests. Q13. How is aortic regurgitation diagnosed? A 13. Aortic regurgitation is diagnosed with echocardiography, the same as mitral regurgitation. An EKG and chest X-ray may show left ventricular hypertrophy, thickening of the heart muscle. Treatment. Q14. What is the treatment for aortic regurgitation? A 14. The treatment for aortic regurgitation includes ACE inhibitors, ASAs, angiotensin receptor blockers, ARBs, or nifedipine to dilate the blood vessels and increase forward blood flow. However, these do not slow the disease progression. Digoxin and diuretics are used for symptom control in CHF, but their benefit is limited. Q15. When is surgical valve replacement needed in aortic regurgitation? A 15. Surgical valve replacement is needed when there is acute valve rupture, such as after a myocardial infarction, heart attack. The left ventricle has started to dilate excessively, or if the ejection fraction, EF, drops below 55%. Surgery is also performed when the left ventricular end systolic diameter is larger than 55 millimeters. Bicuspid aortic valve. Q16. What is a bicuspid aortic valve? A 16. A bicuspid aortic valve is a congenital condition where the aortic valve has only 2 leaflets instead of the normal 3. This condition affects about 1 to 2% of the population. Q17. What problems can arise from a bicuspid aortic valve? A 17. The most common problem with a bicuspid aortic valve is aortic stenosis, AS, which is the narrowing of the aortic valve. Over time, this can lead to aortic regurgitation and dilation of the aorta, the main artery. Q18. How should a person with a bicuspid aortic valve be monitored? A 18. If a person with a bicuspid aortic valve is asymptomatic and under age 30, they should be monitored with echocardiograms every 1 to 2 years to check the function of the valve and the size of the aorta. Q19. What treatments are needed for a bicuspid aortic valve? A 19. Hypertension, high blood pressure, should be treated to prevent further damage to the valve. If left ventricular dysfunction and symptoms develop. Mitral valve prolapse, MVP. Definition and etiology. Q1. What is mitral valve prolapse, MVP? A 1. Mitral valve prolapse, MVP, is a condition where one or both of the mitral valve leaflets, flaps in the heart, bulge or prolapse into the left atrium during systole when the heart contracts. It is so common that it is considered a normal variation, occurring in 2% to 5% of the population, particularly in women. Q2. What causes mitral valve prolapse? A 2. Mitral valve prolapse, MVP, can occur on its own as a normal variation, but it can also be linked to conditions like Marfan syndrome and Ehlers-Danlos syndrome, which are genetic disorders that affect connective tissue. Presentation. Q3. What are the symptoms of mitral valve prolapse? 3. Mitral valve prolapse is often asymptomatic, doesn't cause symptoms. When symptoms do occur, they are different from other forms of valvular heart disease and typically do not involve the usual symptoms of congestive heart failure, CHF. The most common symptoms are atypical chest pain that is not typical for heart problems, palpitations, feeling your heart beat irregularly or strongly, panic attacks. Q4. How is the murmur of mitral valve prolapse different from other heart murmurs? 4. The murmur in mitral valve prolapse is characterized by a mid-systolic click, which happens in the middle of the heart's contraction. When the prolapse is severe, this click is followed by a murmur due to mitral regurgitation, backward flow of blood through the mitral valve. Auscultatory maneuvers, effects of different movements. Q5. How do certain maneuvers affect the murmur of mitral valve prolapse? 5. The murmur of mitral valve prolapse reacts differently from other heart murmurs. Valsalva, holding your breath and straining, and standing reduce the amount of blood returning to the heart venous. Return, which worsens the murmur of MVP. Squatting or hand grip, squeezing your hands tightly, increase the size of the left ventricle, which improves the murmur or may make it disappear. Diagnostic test. Q6. How is mitral valve prolapse diagnosed? 6. The best way to diagnose mitral valve prolapse is through echocardiography, an ultrasound of the heart. This allows the doctor to see the mitral valve and how it is functioning. Catheterization, inserting a tube into the heart to measure pressure, is rarely necessary because the exact pressure is not needed to determine treatment. Treatment. Q7. How is mitral valve prolapse treated? 7. Treatment for mitral valve prolapse includes beta blockers. These can be prescribed if the patient is experiencing symptoms like palpitations or anxiety. Beta blockers help to slow down the heart and reduce stress on the heart. Valve repair. In rare cases, the valve can be repaired using a catheter by placing a clip to tighten the valve. This is usually only needed if there is significant mitral regurgitation. Q8. Is surgical repair of the valve needed in mitral valve prolapse? 8. Surgical repair of the mitral valve is rarely necessary. Usually, the condition can be managed with less invasive treatments like medications and catheter-based repairs. Q9. Is endocarditis prophylaxis needed in mitral valve prolapse? 9. Endocarditis prophylaxis, antibiotics to prevent heart infections, is not recommended for people with mitral valve prolapse, even if they have a murmur of mitral regurgitation. This is because the risk of developing an infection in the heart is very low in these patients. Summary. Q10. Is mitral valve prolapse a serious condition? 10. Mitral valve prolapse is generally not a serious condition for most people. It is often asymptomatic and doesn't lead to major health problems. When symptoms occur, they can usually be managed with lifestyle changes or medications like beta blockers. Surgery is rarely needed. Cardiomyopathy. Definition and etiology. Q1. What is cardiomyopathy? 1. Cardiomyopathy is a disease of the heart muscle, myocardium, where the heart becomes abnormal in how it contracts or relaxes. This means the heart cannot pump blood properly. The problems in cardiomyopathy are not due to issues with the heart, valves, or heart sounds, but rather the heart muscle's inability to work as it should. Q2. What are the types of cardiomyopathy? 2. There are 3 main types of cardiomyopathy. Dilated cardiomyopathy, heart becomes enlarged and weak. Hypertrophic cardiomyopathy, heart muscle becomes thickened. Restrictive cardiomyopathy, heart muscle becomes stiff. Q3. What are the terms related to cardiomyopathy? 3. The terms dilated cardiomyopathy, systolic dysfunction, and low ejection fraction are often used together because they describe the heart not pumping effectively. Hypertrophic cardiomyopathy is often associated with diastolic dysfunction, meaning the heart has trouble relaxing and filling with blood. Another term is cardiac failure. with preserved ejection fraction, which means the heart doesn't pump well, but it still pumps out a normal amount of blood when it beats. Presentation. Q4. What symptoms are seen in cardiomyopathy? A4. The most common symptom of cardiomyopathy is shortness of breath, especially when exercising. Other symptoms include edema, swelling, usually in the legs, rales, crackling sounds heard in the lungs due to fluid buildup, jugular venous distension, JVD, swelling in the neck veins. These symptoms are common in all forms of cardiomyopathy and resemble symptoms of congestive heart failure, CHF. Diagnostic tests. Q5. How is cardiomyopathy diagnosed? A5. The best initial test for diagnosing cardiomyopathy is echocardiography, an ultrasound of the heart. This can show how well the heart is pumping and whether the chambers are enlarged. Other tests like EKG, electrocardiogram, and chest X-ray may be done, but they don't specifically confirm cardiomyopathy. They help assess other heart functions. Treatment. Q6. How is cardiomyopathy treated? A6. Cardiomyopathy is typically treated with diuretics, medications that reduce fluid buildup, for all types. Other treatments depend on the type of cardiomyopathy. The main goal is to treat the symptoms and improve heart function. Dilated cardiomyopathy. Q7. What causes dilated cardiomyopathy? A7. Dilated cardiomyopathy can be caused by previous heart attack, MI, and lack of blood flow to the heart muscle, alcohol abuse, post-viral myocarditis, inflammation of the heart muscle after a viral infection, radiation therapy, toxins such as the chemotherapy drug doxorubicin, Chagas disease, a parasitic infection. Presentation and diagnostic tests for dilated cardiomyopathy. Q8. What are the symptoms of dilated cardiomyopathy? A8. The symptoms of dilated cardiomyopathy are similar to CHF and include shortness of breath, fatigue, swelling, and fluid in the lungs, leading to rales and gallops. Diagnosis is often done using echocardiography, but EKG and chest X-ray provide additional information. Treatment for dilated cardiomyopathy. Q9. How is dilated cardiomyopathy treated? A9. Several medications help lower the risk of death from dilated cardiomyopathy. ACE inhibitors, like lisinopril, and ARBs, like losartan, help relax blood vessels and reduce heart strain. Beta blockers, like metoprolol or carvedilol, slow the heart rate and improve pumping efficiency. Spironolactone, a type of diuretic, helps prevent fluid buildup and improves heart function. For symptom control, diuretics and digoxin, a heart-strengthening drug, can be used. Q10. What is a biventricular pacemaker, and when is it used in dilated cardiomyopathy? A10. A biventricular pacemaker is a device implanted to help both sides of the heart beat together, improving the heart's efficiency. It is recommended for patients with dilated cardiomyopathy if the QRS interval, a part of the heart's electrical cycle, is wide, more than 140 milliseconds, which means the heart's electrical signals are delayed. This device helps improve symptoms and survival. Q11. What is an implantable cardioverter/defibrillator, ICD, and how does it help in dilated cardiomyopathy? 11. An implantable cardioverter/defibrillator, ICD, is a device that detects and corrects life-threatening heart rhythms. It is used in patients with low ejection fraction, less than 30%, to prevent sudden cardiac arrest. The ICD helps reduce mortality in certain patients with dilated cardiomyopathy. Key points about management. Q12. What is the role of ACE inhibitors, ARBs, and beta blockers in dilated cardiomyopathy? A12. ACE inhibitors, ARBs, and beta blockers are important because ACE inhibitors and ARBs help reduce the strain on the heart by relaxing blood vessels. Beta blockers help slow the heart rate and reduce its workload, improving heart function. These medications help improve survival and reduce symptoms in people with dilated cardiomyopathy. Q13. When is surgical treatment needed in dilated cardiomyopathy? A13. Surgical treatment may be needed when the heart's electrical system is severely impaired, wide QRS interval, or if other treatments are not effective. The placement of a biventricular pacemaker or an ICD might be necessary to help improve heart function or prevent sudden death. Summary. Q14. How does the treatment differ among the types of cardiomyopathy? 14. While all types of cardiomyopathy are treated with diuretics, the main differences in treatment depend on the type. Dilated cardiomyopathy has the broadest range of medications to lower mortality, such as ACE inhibitors, ARBs, and beta blockers. Hypertrophic cardiomyopathy often focuses on medications to manage symptoms. Restrictive cardiomyopathy often involves treatments aimed at managing fluid and heart function, with diuretics being common. Hypertrophic cardiomyopathy, heart failure with preserved ejection fraction, HFpEF. Definition and etiology. Q1. What is hypertrophic cardiomyopathy, HCM? 1. Hypertrophic cardiomyopathy, HCM, is a condition where the heart muscle thickens, hypertrophies due to stress from factors like high blood pressure, hypertension. The thickened heart muscle has difficulty relaxing during diastole, the phase when the heart fills with blood, making it harder for the heart to receive blood, causing shortness of breath. Q2. How does hypertrophic obstructive cardiomyopathy, HOCM, differ from HCM? 2. Hypertrophic obstructive cardiomyopathy, HOCM, is a genetic disorder, unlike HCM, and involves a specific shape change in the heart septum, the wall between the left and right sides of the heart. This altered shape blocks the blood flow out of the heart, causing an obstruction. In HCM, the heart thickens due to stress, but does not necessarily block blood flow. Differences between HCM and other forms of cardiomyopathy. Q3. What are the key differences between HCM and other forms of cardiomyopathy? 3. The main differences include S4 gallop, a type of abnormal heart sound heard in HCM. Right heart failure symptoms, such as ascites, fluid buildup in the abdomen, and enlargement of the liver and spleen, are less common in HCM compared to other forms of cardiomyopathy. Treatment. Q4. What is the treatment for HFpEF, hypertrophic cardiomyopathy with preserved ejection fraction? 4. The primary treatment for HFpEF is controlling hypertension, high blood pressure. While certain medications like ACE inhibitors, ARBs, and beta blockers help control hypertension, they do not improve mortality, life expectancy in HFpEF patients. These medications are used to manage blood pressure but are not life-saving in this condition. Q5. Should beta blockers be used for hypertrophic cardiomyopathy, HCM? 5. Beta blockers should not be used specifically for treating HCM because they do not improve the outcomes in this condition. Q6. When should spironolactone be used in HFpEF? 6. Spironolactone is used in HFpEF when the ejection fraction, EF, is greater than 45%, meaning the heart still pumps out a good amount of blood. The BNP, brain natriuretic peptide, level is elevated, indicating heart strain. There has been a hospitalization for heart failure in the past year. However, spironolactone does not reduce mortality in HFpEF patients. Symptoms of hypertrophic obstructive cardiomyopathy, HOCM. Q7. What are the symptoms of HOCM? 7. Symptoms of HOCM include dyspnea, shortness of breath, similar to other forms of cardiomyopathy, chest pain, angina, syncope, fainting, and lightheadedness due to obstruction of blood flow, sudden death, particularly in athletes, healthy young people. Symptoms worsen with anything that increases heart rate, such as exercise, dehydration, or use of diuretics. Q8. What worsens symptoms in HOCM? 8. Symptoms of HOCM worsen with exercise, which increases the heart's workload, dehydration, which makes the heart work harder, diuretics, which reduce blood volume, anything that decreases left ventricular chamber size, such as ACE inhibitors, ARBs, digoxin, and hydralazine. Diagnostic tests for HOCM. Q9. How is HOCM diagnosed? 9. The best initial test for diagnosing HOCM is echocardiography, which can show the thickened septum, the wall between the heart chambers that is characteristic of the condition. The septum is typically 1.5 times thicker than the posterior wall of the heart. EKG may show nonspecific ST and T wave changes and left ventricular hypertrophy, LVH. EKG can be normal in about 25% of cases. Treatment for HOCM. Q10. What is the best initial therapy for HOCM? A 10. The best initial therapy for HOCM is beta blockers, which help to slow down the heart rate and reduce the heart's workload. This treatment is especially helpful in preventing the worsening of symptoms. Q11. What other medications are used in HOCM treatment? 11. Other medications used for HOCM include verapamil and disopyramide, which have strong negative inotropic effects. They reduce the strength of the hearts. Contractions, helping to reduce obstruction in the heart. Diuretics may help in HCM, but are contraindicated in HOCM because they can worsen symptoms. Q12. What is septal ablation, and when is it used in HOCM? A 12. Septal ablation is a procedure where alcohol is injected into the thickened septum to cause small areas of the septal muscle to die, infarct. This can help reduce the obstruction in HOCM. This procedure is done before considering surgical options. Q13. What is surgical myomectomy, and when is it used in HOCM? A 13. Surgical myomectomy is the removal of part of the thickened septum in the heart. It is the ultimate treatment for HOCM. When medications and catheter procedures, like septal ablation, fail to relieve symptoms. Specific therapy for HOCM. Q14. When is an implantable defibrillator used in HOCM? A 14. An implantable defibrillator, ICD, should be used in any patient with HOCM who experiences syncope, fainting. This device can prevent sudden cardiac death, which is a risk in patients with severe HOCM. Q15. What medication should never be used in HOCM? A 15. Digoxin should never be used in HOCM because it can increase the force of heart contractions and worsen the obstruction of the heart. Differences in therapy between hypertrophic cardiomyopathy and dilated cardiomyopathy. Q16. How does the treatment of HCM differ from dilated cardiomyopathy, DCM? A 16. The treatment differences include beta blockers are used in HCM, but not in DCM. Diuretics are used in both conditions to help with fluid buildup. ACE inhibitors, ASAs, and ARBs have unclear benefits in HCM, but are effective in DCM. Spironolactone is used in both, though its effectiveness in HCM is less clear. Digoxin is used in DCM, but never in HCM. Q17. Why are ACE inhibitors and diuretics not helpful in HOCM? A 17. In HOCM, ACE inhibitors and diuretics are not helpful because they can reduce the left ventricular chamber size, which worsens the obstruction in the heart. This is a major difference between HOCM and HCM. Restrictive cardiomyopathy. Definition and etiology. Q1. What is restrictive cardiomyopathy? A 1. Restrictive cardiomyopathy is a heart condition where the heart's ability to contract and relax properly is impaired. The heart becomes stiff and less flexible because it is filled with substances that make it immobile. This condition combines the worst features of both dilated cardiomyopathy, where the heart becomes enlarged and weakened, and hypertrophic cardiomyopathy, where the heart muscle thickens. Q2. What causes restrictive cardiomyopathy? A 2. Restrictive cardiomyopathy can be caused by several diseases and conditions that lead to stiffening of the heart muscle. These include sarcoidosis, a disease where clusters of inflammatory cells form in organs, including the heart. Amyloid, a condition where abnormal proteins, amyloid, deposit in organs, including the heart. Hemochromatosis, a disorder where excess iron builds up in the body, including the heart. Endomyocardial fibrosis, a condition that leads to scarring and stiffening of the heart's inner lining. Scleroderma, a disease that causes thickening and hardening of the skin and connective tissues, including the heart. Presentation symptoms. Q3. What are the most common symptoms of restrictive cardiomyopathy? A 3. The most common symptom is dyspnea, shortness of breath. Other signs include ascites, fluid buildup in the abdomen, edema, swelling in the legs and feet, jugular venous distension (JVD), swelling of veins in the neck, enlargement of the liver and spleen due to right heart failure. Q4. What causes pulmonary hypertension in restrictive cardiomyopathy? 4. Pulmonary hypertension occurs in restrictive cardiomyopathy because the heart's inability to properly fill with blood leads to increase pressure in the lungs. This pressure increase is known as wedge pressure. Q5. What is Kussmaul sign? 5. Kussmaul sign refers to an increase in jugular venous pressure, JVP, during inhalation. This is an abnormal finding and is seen in restrictive cardiomyopathy due to impaired right heart filling. Diagnostic tests. Q6. What is the best test to diagnose restrictive cardiomyopathy? 6. The best initial test for diagnosing restrictive cardiomyopathy is echocardiography, ultrasound of the heart. This test can show the stiffness of the heart and the poor filling of the heart chambers. Q7. What does the ejection fraction look like in restrictive cardiomyopathy? 7. The ejection fraction, the percentage of blood pumped out with each heartbeat, can be normal or elevated in restrictive cardiomyopathy. This is because the heart may still pump blood effectively, but it struggles to fill properly due to stiffness. Q8. What does the EKG show in restrictive cardiomyopathy? 8. The EKG in restrictive cardiomyopathy typically shows low voltage, a weak electrical signal, which reflects the stiffened heart tissue. Q9. How does amyloid involvement appear on imaging? 9. When amyloid deposits affect the heart, echocardiography or cardiac MRI can show speckling of the heart septum, the wall between the heart chambers. Q10. What is the most accurate test for diagnosing restrictive cardiomyopathy? 10. The most accurate test is an endomyocardial biopsy, a tissue sample from the heart muscle. However, this test is rarely performed because the diagnosis can often be made based on biopsies from other parts of the body where amyloid or other substances are present. Treatment. Q11. How is restrictive cardiomyopathy treated? 11. The main treatment is to treat the underlying cause of the condition. For example, if the cause is amyloid, treatment may focus on managing amyloidosis. Q12. Can diuretics help in restrictive cardiomyopathy? 12. Yes, diuretics, medications that help remove excess fluid from the body, can help relieve some of the symptoms of pulmonary hypertension and signs of right heart failure, such as swelling and fluid retention. However, they do not treat the underlying stiffness of the heart. Q13. Is there a specific therapy for restrictive cardiomyopathy? 13. There is no specific therapy for restrictive cardiomyopathy other than managing the underlying cause. Murmurs and the effects of maneuvers. Q14. How do maneuvers affect heart murmurs? 14. Different maneuvers can increase or decrease the intensity of heart murmurs. For example, squatting or leg raising increases blood flow to the heart and increases murmurs for conditions like mitral stenosis and aortic stenosis. Standing or Valsalva, exhaling forcefully with a closed mouth, reduces blood return to the heart and decreases murmurs for conditions like mitral stenosis and aortic stenosis. Q15. How do murmurs behave with mitral valve prolapse, MVP, and hypertrophic obstructive cardiomyopathy, HOCM? 15. In conditions like MVP and HOCM, the murmurs behave oppositely. In MVP, the murmur increases when standing or with Valsalva because these maneuvers reduce the left ventricular size and worsen the regurgitation. In HOCM, the murmur also increases when standing or with Valsalva because these maneuvers decrease blood flow and increase obstruction in the heart. Effects of maneuvers. Q16. How does standing suddenly affect the heart? 16. Standing suddenly opens the veins in the legs, reducing the blood returning to the heart, which can lower the volume of blood the heart pumps. This maneuver is similar to using a diuretic because it also reduces venous return to the heart. Q17. How does Valsalva affect the heart? 17. Valsalva, exhaling against a closed glottis, increases intrathoracic pressure, which makes it harder for blood to return to the heart. This mimics the effect of a diuretic by reducing venous return. Q18. What does hand grip do to the heart? 18. Hand grip, squeezing the hands tightly, increases the afterload resistance the heart must overcome to pump blood. This increases the work of the heart and fills the left ventricle more, making the heart pump against higher resistance. Q19. What is the effect of amyl nitrate on the heart? 19. Amyl nitrate is a vasodilator. It relaxes blood vessels, which reduces the resistance the heart faces, similar to the effect of ACE inhibitors. It helps to empty the left ventricle by lowering the afterload, making it easier for the heart to pump. Summary of maneuvers. Q20. How do standing and Valsalva affect murmurs? 20. Standing and Valsalva decrease venous return to the heart and decrease the murmurs of stenotic, narrowed, and regurgitant leaky valves by reducing blood volume. However, they worsen murmurs of mitral valve prolapse, MVP, and hypertrophic obstructive cardiomyopathy, HOCM, by making these conditions worse. Q21. How do hand grip and amyl nitrate affect murmurs? 21. Hand grip increases afterload, making left ventricle filling fuller and potentially increasing murmurs related to stenotic valves. Amyl nitrate lowers afterload and can soften murmurs, making them less noticeable in conditions treated with vasodilators like ACE inhibitors. Maneuvers and their effects on heart lesions. General concept of maneuvers and treatment. Q1. How do maneuvers relate to treatment for heart lesions? 1. Certain maneuvers, physical actions, can have effects similar to medical treatments for heart lesions, such as those caused by valve problems like regurgitation. For example, amyl nitrate is a drug that increases blood flow forward in the heart and helps reduce backward flow, similar to how medications like ACE inhibitors, ARBs, and nifedipine treat regurgitant lesions by making it easier for blood to move forward. Q2. What is the effect of amyl nitrate on regurgitant lesions? 2. Amyl nitrate works by increasing forward blood flow and decreasing backward flow. This helps reduce the symptoms of regurgitant lesions, which occur when blood leaks backward through a valve. Amyl nitrate acts like a vasodilator, relaxing blood vessels to make it easier for blood to flow in the right direction. Effects of hand grip. Q3. How does hand grip affect heart lesions? 3. Hand grip, squeezing your hands tightly, increases the resistance that the heart must overcome to pump blood. This increases afterload, the force against which the heart pumps. As a result, hand grip makes the heart larger and fuller, which helps improve conditions like hypertrophic obstructive cardiomyopathy, HOCM, by reducing the obstruction of blood flow in the heart. Q4. How does hand grip improve HOCM? 4. HOCM involves obstruction to blood flow in the heart, especially when the heart muscle becomes thicker than normal. When you perform hand grip, it increases afterload, which makes the heart bigger and reduces the obstruction in HOCM, allowing better blood flow. Q5. How does hand grip affect the heart in mitral valve prolapse, MVP? 5. In mitral valve prolapse, the valve does not close properly, causing blood to flow backward into the heart. Hand grip improves this condition because the heart becomes fuller, which can help reduce the backward flow of blood, improving the condition. Effects of amyl nitrate. Q6. How does amyl nitrate affect the heart compared to hand grip? 6. Amyl nitrate has the opposite effect of hand grip. It decreases afterload, reduces resistance, and empties the heart by relaxing blood vessels. This makes the heart smaller and less full, which can worsen conditions like mitral valve prolapse, MVP, and HOCM, because the smaller heart worsens the obstruction in HOCM and makes MVP worse by increasing the backward flow of blood. Q7. Why does amyl nitrate worsen MVP and HOCM? 7. Amyl nitrate reduces the size of the heart, making it smaller and emptier. This worsens MVP, where blood leaks backward. through the valve because the heart is not as full, which can cause more backward blood flow. Similarly, in HOCM, the smaller heart increases the obstruction in the blood flow, worsening the condition myocarditis. What is myocarditis? Q8. What is myocarditis? 8. Myocarditis is an inflammation of the heart muscle. It can be caused by infections, toxins, or autoimmune diseases. It affects the heart's ability to pump blood and can be very serious. The inflammation damages the heart tissue, weakening the heart's function. Q9. What causes myocarditis? 9. Myocarditis can be caused by infections like viruses, e.g., Coxsackie virus, bacteria, or fungi. Toxins, such as the chemotherapy drug adriamycin. Autoimmune diseases like lupus or rheumatoid arthritis. Symptoms and diagnosis. Q10. What are the symptoms of myocarditis? 10. The symptoms of myocarditis can vary. Some patients are asymptomatic, show no symptoms. Others may experience dyspnea, shortness of breath. In severe cases, it can present like a heart attack, MI, with chest pain and ST segment elevation on an EKG. Q11. How can myocarditis be diagnosed? 11. The only accurate test for diagnosing myocarditis is a biopsy, taking a small tissue sample from the heart. However, this test is rarely done. Instead, doctors often use tests like echocardiography to see if the ejection fraction, amount of blood the heart pumps out, is reduced. Q12. How does myocarditis show up on an EKG? 12. Myocarditis can cause abnormalities on an EKG, electrocardiogram, but it is not specific. ST segment elevation can appear, mimicking a heart attack. There may also be other irregularities, but these changes alone cannot confirm myocarditis. Treatment of myocarditis. Q13. How is myocarditis treated? 13. Myocarditis is treated by managing symptoms and underlying causes. ACE inhibitors and beta blockers are used if the ejection fraction, heart pumping ability, is low. Statins and antiplatelet medications are not used because they are for coronary artery disease, which is not involved in myocarditis. Steroids and 4-immunoglobulin, IVIG, are not helpful in viral myocarditis. Q14. Why don't steroids help in viral myocarditis? 14. Steroids can actually worsen viral myocarditis because they suppress the immune system, which is needed to fight off the virus. Since viral myocarditis is caused by an infection, suppressing the immune system can make the situation worse. Pericardial disease. What is pericarditis? Q15. What is pericarditis? 15. Pericarditis is inflammation of the pericardium, the protective sac surrounding the heart. It can be caused by infections, autoimmune diseases, chest trauma, or cancer. Q16. What are common causes of pericarditis? 16. Pericarditis can be caused by infections like viruses, most commonly Coxsackie virus, bacteria, or fungi. Autoimmune diseases such as lupus or rheumatoid arthritis, chest trauma, injury to the chest, or cancer near the heart. Symptoms and diagnosis. Q17. What are the symptoms of pericarditis? 17. The main symptom of pericarditis is sharp chest pain, which can change with breathing and body position. The pain usually gets worse when lying flat and improves when sitting up. Q18. What does the EKG show in pericarditis? 18. The EKG in pericarditis shows ST segment elevation in all leads, which is a characteristic finding. The most specific sign is PR segment depression, which is commonly seen in pericarditis. Q19. How is pericarditis treated? 19. The treatment for pericarditis focuses on the underlying cause. If the cause is unknown, NSAIDs like ibuprofen or naproxen are used to reduce inflammation and relieve pain. Colchicine can be used to reduce recurrences of pericarditis. Steroids are generally avoided unless needed for autoimmune causes because they can worsen some types of pericarditis. Q20. How does colchicine help in pericarditis? 20. Colchicine is used to prevent recurrences of pericarditis by reducing inflammation and stabilizing the pericardium. It is especially useful in treating idiopathic, unknown cause, pericarditis. Pericardial tamponade. Definition and causes. Q1. What is pericardial tamponade? 1. Pericardial tamponade is a condition where fluid accumulates in the pericardium, the sac around the heart, putting pressure on the heart and affecting its ability to pump blood. This can happen due to inflammation, pericarditis, trauma, or other causes that lead to fluid building up. Q2. What causes pericardial tamponade? 2. Pericardial tamponade can be caused by pericarditis, inflammation of the pericardium, from infections, autoimmune diseases, or other factors. Trauma, such as injury that causes bleeding into the pericardium. Even small amounts of fluid, 50 milliliters, can cause tamponade if they accumulate quickly. If fluid builds up slowly over weeks to months, the pericardium can stretch to accommodate up to 2 liters. How it affects the heart. Q3. Why does pericardial tamponade affect the right side of the heart first? 3. The right side of the heart is affected first because the walls of the right chambers, atria and ventricle, are thinner than those of the left side. This makes them more prone to compression from the accumulated fluid, leading to tamponade. Symptoms of pericardial tamponade. Q4. What are the symptoms of pericardial tamponade? 4. Symptoms of pericardial tamponade include hypotension, low blood pressure, tachycardia, rapid heart rate, distended neck veins due to increased pressure in the veins, clear lungs, lungs are not affected. Physical exam findings. Q5. What is pulsus paradoxus and how is it related to pericardial tamponade? 5. Pulsus paradoxus is when the blood pressure drops by more than 10 millimeters of mercury during inhalation. It is often seen in pericardial tamponade because the pressure from the fluid around the heart makes it harder for the heart to fill during inhalation, causing this drop in blood pressure. Diagnostic tests. Q6. What tests are used to diagnose pericardial tamponade? 6. The following tests help diagnose pericardial tamponade. EKG shows electrical alternance, a change in the height of the QRS complexes between heartbeats. Chest X-ray can show an enlarged cardiac shadow or globular heart indicating fluid buildup. Echocardiogram shows diastolic collapse of the right atrium and ventricle. The chambers of the heart collapse when they ill with too much fluid. Right heart catheterization measures pressures inside the heart, showing equalized pressures during diastole, the heart's resting phase. Treatment. Q7. How is pericardial tamponade treated? 7. Treatment for pericardial tamponade includes pericardiocentesis. A needle is used to drain the fluid and relieve the pressure on the heart. Intravenous fluids, given to help stabilize blood pressure. If the tamponade is recurrent, a hole or window may be made in the pericardium to allow fluid to drain more easily. Diuretics. These are not recommended because they can worsen the collapse of the heart by decreasing the blood volume. Too much. Constrictive pericarditis. Definition and causes. Q8. What is constrictive pericarditis? 8. Constrictive pericarditis is a condition where the pericardium, the heart sac, becomes stiff, calcified, and fibrotic over time. This makes it difficult for the heart to fill properly, especially the right side, leading to symptoms of heart failure. Q9. What causes constrictive pericarditis? 9. Constrictive pericarditis can be caused by any type of pericarditis, inflammation of the pericardium that goes on for a long time, such as from tuberculosis. The inflammation causes calcification and fibrosis, scarring, that restricts heart movement. Symptoms of constrictive pericarditis. Q10. What are the symptoms of constrictive pericarditis? 10. Constrictive pericarditis causes right heart failure, and symptoms include edema, swelling in the legs, ascites, fluid buildup in the abdomen, enlarged liver and spleen due to blood backing up in the body, jugular venous distension, JVD, swollen neck veins, physical exam findings. Q11. What is the Kussmaul sign and how is it related to constrictive pericarditis? 11. Kussmaul sign is when neck veins, JVD, increase on inhalation. Normally, they should go down. This happens in Constrictive pericarditis, because the stiff pericardium prevents the heart from filling properly, causing venous pressure to rise. During inhalation. Q12. What is the knock sound associated with constrictive pericarditis? A 12. The knock is an extra hard sound heard during diastole, when the heart is filling with blood. It occurs because as the heart fills, it hits the stiff, rigid pericardium, causing a distinct sound. This is a key feature of constrictive pericarditis. Diagnostic tests. Q13. What tests are used to diagnose constrictive pericarditis? A 13. Diagnostic tests for constrictive pericarditis include chest X-ray, shows calcification and fibrosis in the pericardium, which is a hallmark of the disease. CT scan or MRI, more accurate than chest X-ray for assessing the degree of pericardial thickening, but usually only done after. An initial X-ray, echocardiogram, helps rule out other causes like right ventricular hypertrophy or cardiomyopathy, as these conditions also cause similar symptoms but involve the heart muscle, not the pericardium. Treatment. Q14. How is constrictive pericarditis treated? A 14. Treatment for constrictive pericarditis includes diuretics, to relieve edema, swelling, and organ enlargement by reducing fluid buildup. Surgical removal of the pericardium, pericardiectomy. This is done if the pericardium is severely stiff and causing symptoms of heart failure. Peripheral artery disease, PAD. Definition and causes. Q1. What is peripheral artery disease, PAD? A 1. Peripheral artery disease, PAD, is a condition where the arteries in the legs become narrowed or blocked, stenosis, due to the buildup of plaque. This reduces blood flow to the legs, causing symptoms like pain when walking. Q2. What causes PAD? A 2. PAD shares common causes with diseases like coronary artery disease, heart and carotid artery disease, neck, including diabetes mellitus, high blood sugar, hyperlipidemia, high cholesterol, hypertension, high blood pressure, tobacco smoking. Symptoms of PAD. Q3. What are the symptoms of PAD? A 3. PAD often causes leg pain in the calf muscles when walking, which gets better with rest. This pain is typically triggered by physical activity, especially walking up or down hills. Severe PAD can lead to loss of hair on the legs, dry, shiny skin due to loss of sweat glands and sebaceous glands. Q4. How does spinal stenosis pain differ from PAD pain? A 4. Spinal stenosis pain tends to get worse when walking down hills because it is aggravated by leaning back. In contrast, PAD pain occurs more often when walking up or down hills and is relieved by rest. Diagnostic tests. Q5. How is PAD diagnosed? A 5. The main diagnostic tests for PAD are ankle brachial index, ABI. This test compares the blood pressure in your ankles and arms. Normally, the ankle pressure should be the same or slightly higher than the arm pressure. If the ankle pressure is much lower, it suggests PAD. An ABI less than 0.9 indicates disease. Angiogram. This is the most accurate test to check for PAD, but it is usually only done if the patient needs surgery to fix the blocked arteries. Treatment. Q6. What are the treatments for PAD? A 6. The main treatments for PAD are aspirin or Vorapaxar. These are blood-thinning medications to reduce the risk of clotting. Stopping smoking. Smoking is a major cause of PAD, and quitting is crucial to treatment. Solastazole. This medication helps improve blood flow and relieve symptoms of PAD. It is considered the most effective drug for PAD. Q7. When is surgery needed for PAD? A 7. If medications like solastazole and lifestyle changes do not effectively treat PAD, surgery may be needed. This usually involves bypass surgery to redirect blood flow around the blocked arteries. Medications and lifestyle. Q8. What are the benefits of Vorapaxar in treating PAD? A 8. Vorapaxar is an antiplatelet medication used to prevent blood clots in patients with PAD. It can be used as an alternative to aspirin or clopidogrel, but it should not be used in patients with a history of stroke or TIA, transient ischemic attack, due to an increased risk of bleeding. Q9. What medications should be avoided in PAD treatment? A 9. Calcium blockers, a class of drugs used to treat high blood pressure, do not help with PAD and should be avoided for treating this condition. Screening and prevention. Q10. Is there a routine screening for PAD? A 10. There is no routine screening for PAD unless a person is at high risk, as there is no proven benefit in terms of reducing mortality from screening. Q11. What should be controlled in all major vascular diseases, including PAD? 11. The following factors should be controlled in all major vascular diseases: blood pressure BP, low-density lipoprotein, LDL cholesterol levels, with a target of 70 and statin medications for everyone. Diabetes, maintaining blood sugar control. Key points for treatment and prevention. Q12. What is the most important medication for PAD treatment? A 12. The most effective medication for PAD is cilostazol, which helps increase blood flow and reduce symptoms like pain when walking. Q13. What role does smoking cessation play in treating PAD? A 13. Smoking cessation is crucial for treating PAD because smoking is one of the primary causes of arterial narrowing and reduced blood flow. Quitting helps slow the progression of the disease and improve symptoms. Peripartum cardiomyopathy and Eisenmenger syndrome. Peripartum cardiomyopathy. Q1. What is peripartum cardiomyopathy? A 1. Peripartum cardiomyopathy is a type of heart disease that occurs during pregnancy or shortly after childbirth. In this condition, the left ventricle, LV, of the heart becomes weakened, which affects the heart's ability to pump blood. Q2. What causes peripartum cardiomyopathy? A 2. The cause is unknown, but it is believed that some pregnant women develop antibodies that attack the heart muscle. Myocardium. This leads to heart dysfunction, but in many cases, the dysfunction is reversible and improves over time. Q3. How is left ventricular dysfunction in peripartum cardiomyopathy treated? A 3. The treatment for peripartum cardiomyopathy is similar to the treatment for dilated cardiomyopathy, a condition where the heart becomes enlarged and weakened. The treatment options include ACE inhibitors, ASAs, or angiotensin receptor blockers, ARBs, medications that help relax blood vessels and reduce the heart's workload, beta blockers, drugs that help slow the heart rate and reduce the heart's workload, spironolactone, a medication that helps reduce fluid buildup in the body, diuretics, drugs that help remove excess fluid from the body, digoxin, a drug that helps strengthen the heart's contractions. Q4. What happens if peripartum cardiomyopathy does not improve? A 4. If the left ventricular dysfunction does not improve over time, heart transplantation may be needed to replace the damaged heart with a healthy one. Q5. How does pregnancy affect peripartum cardiomyopathy? A 5. Peripartum cardiomyopathy often develops after delivery. However, if a woman with this condition becomes pregnant again, it can lead to the production of large amounts of antibodies against the heart muscle, which can worsen the condition. Q6. Can a woman with peripartum cardiomyopathy use ASAs/ARBs during pregnancy? A 6. Yes, ASAs/ARBs are considered acceptable to use in women with peripartum cardiomyopathy, especially because the condition develops after delivery when the pregnancy is over, so the medication's risks are minimized. Eisenmenger syndrome. Q7. What is Eisenmenger syndrome? A 7. Eisenmenger syndrome is a complication of pulmonary hypertension, high blood pressure in the lungs. It typically occurs in individuals with a ventricular septal defect, a hole in the heart, that initially causes blood to flow from the left side to the right side of the heart, left to right shunting. Over time, pulmonary hypertension develops, and the shunt reverses to a right to left shunt, which causes blood to flow from the right side of the heart to the left side, bypassing the lungs and leading to low oxygen levels in the body. Q8. How does Eisenmenger syndrome develop? A 8. Eisenmenger syndrome develops when a ventricular septal defect causes significant left-to-right shunting of blood, which, over time, causes pulmonary hypertension. Once the pressure in the lungs becomes very high, the blood flow through the shunt reverses, leading to a right-to-left shunt. Q9. What is a tip for identifying the worst cardiac disease in pregnant women? A 9. If peripartum cardiomyopathy is not listed as an option in a question about the worst cardiac disease in pregnant women, the answer is likely Eisenmenger syndrome because it is one of the most serious heart conditions that can occur during pregnancy. Effects of pregnancy on heart conditions. Q10. How does pregnancy affect the heart? A 10. Pregnancy increases the plasma volume by 50%, meaning that the amount of fluid in the bloodstream increases. This can put extra stress on the heart, especially in women with certain heart conditions. Q11. How does pregnancy affect mitral stenosis? 11. Mitral stenosis, a condition where the mitral valve in the heart becomes narrowed, can worsen during pregnancy. However, it does not worsen as much as peripartum cardiomyopathy or Eisenmenger syndrome. Summary of key points. Q12. What is the treatment for peripartum cardiomyopathy? A 12. The treatment for peripartum cardiomyopathy includes the same medications used for dilated cardiomyopathy, such as ACE inhibitors, beta blockers, spironolactone, diuretics, and digoxin. If the heart function does not improve, a heart transplant may be necessary. Q13. What is the role of ACE inhibitors and ARBs in peripartum cardiomyopathy? A 13. ACE inhibitors and ARBs help to reduce the heart's workload by relaxing blood vessels, making it easier for the heart to pump blood. They are safe to use in peripartum cardiomyopathy because this condition typically develops after delivery, when the pregnancy is over. Q14. What is the most dangerous heart condition in pregnant women? A 14. Eisenmenger syndrome is considered one of the most dangerous heart conditions in pregnant women due to the high risk of oxygen deprivation and complications from the right-to-left shunt that occurs with pulmonary hypertension.